So in this session, we are going to have 120 MCQs discussion in a quick T&D format. So the idea is that you should be well aware of at least last 5-year PYQs. So FMGE as well as NEET PG. So I've included, and there are some potential questions which may be asked. So in view of that, I've included a few, very few INI-CT questions as well. All right, so you need to confirm me if audio and video is all clear. Only then I'm going to proceed forward. All right, boys and girls, yes. Okay. All right. So before we start, I want all of you to know, I want all of you to understand one very important fact, that what happens is whenever your exam starts to approach, so most of you guys, you start leaving short subjects, which should not be done at all. You have read short subjects, you have read all 19 subjects. There is no point of not doing revision of any of these subjects. If you are not doing revision of any of these subjects, there was no point of doing it in the very beginning altogether. Did you get my point? All right, so please, I know that nearly 17-18 days are left, but I want all of you to go through all the sessions that we have conducted on YouTube, especially these PYQ sessions, because no matter what you do, no matter from where do you do, it is very important for all of you to be well versed with the PYQ of FMG and NEET PG, because we have seen over the years that if not the exact question, there are always some pretty good chances that your previous year topics will be repeated. Now, how do we know which is your special previous year important topic? By going through the PYQs only. Okay, all right, so without wasting any more time, we are going to start. So I have got 120 MCQs, so we will be discussing 120 MCQs, and these MCQs will be in the T&D format. So the best way to attempt MCQ is by the act of elimination. So don't try to simply jump upon the answer. सीधा हम answer के ऊपर नहीं jump करेंगे. In fact, we will remove the option one by one. So for every option you remove, you increase your chances of getting the answer right. Got my point? Okay. Okay, can we move ahead? Yes, with your due permission, I want to move ahead. Yes, let me know in the chat box. Dr. Panic, Dr. Anna, Dr. Khan, Dr. Preeti, Dr. Strange, everyone. All right, चलिए अब हम शुरू करते हैं. सो स्टार्टिंग अप विद द वेरी फर्स्ट क्वेश्चन. अ 3-month-old child with mucus coming from eye on pressing the inner corner, and it is associated with watering. What will be the treatment of this condition? So we have been given the keywords 3 month, which is the age, and mucus coming out. So what is your diagnosis? The examiner is not interested in knowing the diagnosis at this point of time. The examiner wants to know what is the treatment. So diagnosis will be congenital dacryocystitis, right? Okay, congenital dacryocystitis or dacryocystitis. Dacryocystitis can be due to congenital nasolacrimal duct obstruction. Okay, so we are taking from the very basics. Yes, absolutely, it is absolutely enough. So don't need to refer to any other resource for your previous year questions revision. So don't worry about this. Okay, is it done? Yes. All right, so we are talking of congenital nasal lacrimal duct obstruction, which will eventually lead to congenital dacryocystitis, because the tears are not draining through the duct, and because of the blockage, so tears will get collected in the duct. And trust me when I say that the tears, they are the best source for organisms to grow, which will cause inflammation of the nasolacrimal sac. Okay, so what will be your treatment in this condition? So first and foremost, you always ask the parent to go on for a special massage, and that is your Kligler's massage. What is Kligler's massage? You take the little finger and press it from top to bottom, top to bottom, top to bottom, to push the tears down the nasolacrimal duct. So sometimes on putting it on the nasal side and taking your little finger down, you are forcing the tears to actually break the most common cause of nasolacrimal duct obstruction, that is your impedant valve of Hessner. So lacrimal massage is your in fact best treatment or initial treatment. So why do we do lacrimal massage? The other name is Kligler's massage, because you want to break the imperforate valve of Hessner. Imperforate valve of Hessner. Imperforate valve of Hessner. Sir, please tell rest option, explain. Yes, I am coming upon it. So once you have advised the parent to do Kligler's massage, if it is not corrected within 3 months, if it is not corrected within 3 months, call the patient again, yes, and then go on for syringing. Syringing is you take a cannula and put it in front of the syringe filled with distilled water. Try to push the water strongly in the nasolacrimal duct, so the pressure of water may nearly rupture the imperforate valve of Hessner. Okay, still if it is not cured within another 3 months approximately, so you can go on for probing, Bowman's probing. So there are probes which are available. So they are like these stainless steel probe, which you can directly physically put through the canaliculus puncta, which will enter through the nasolacrimal duct, and you simply push it. So this distal end of the probe may break open the imperforate valve of Hessner. Okay, all right. And in the end, if it is still not treated, so after 4 years of age, you cannot do DCR before 4 years, because the entire nasolacrimal apparatus is in developing stage. Okay, so you go on for doing DCR after 4 years once it is entirely fully developed. I hope it is well understood. So the answer to this question remains lacrimal massage. So 3 months, some books mention 2 months. So of course now you know the sequence. First is always massage, then is syringing, then is probing, and lastly there is DCR. Now a person with jaundice and tremors is showing the following finding in the eye. What is the diagnosis? Can you appreciate the peripheral ring which is present? Where it is present? On the cornea. Okay, so this ring which is present on the cornea is KF ring. KF ring means the full form is Kaiser-Fleischer ring. Kaiser-Fleischer ring, and this particular ring is seen where? This particular ring is seen in copper metabolism defects, and one such disease in which there is defect in the copper metabolism is your Wilson's disease. Wilson's disease. Now, because I told you it is very important to touch the nearby topics as well, so you should know one is Wilson's disease, no doubts about it. Now KF ring, which is due to defect in copper metabolism, KF ring is also seen in your PYQ condition known as chalcosis. Chalcosis is when there is copper intraocular foreign body. Copper intraocular foreign body. Just a moment. Yes, copper intraocular foreign body. That is also very important. Acha, if we are talking of chalcosis, can you tell me what is siderosis? This is also your previous year question. It is iron foreign body. So we are doing one question, KF ring, Wilson's disease, but I have given you the answer to another PYQ, chalcosis. Copper foreign body in the eye can also lead to KF ring. Then what is siderosis? Siderosis is iron foreign body in the eye. Okay. All right. Don't confuse KF ring with that of another ring, which is your Fleischer ring. Now, what is Fleischer ring? Fleischer ring is iron deposition. It is iron deposit where? On the epithelium of cornea. Mind you, if I say KF ring, that is Kayser-Fleischer ring, it is copper deposition at the Descemet's membrane of cornea. But Fleischer ring is iron deposition on the epithelium of the cornea, and it is seen in which disease? Keratoconus. It is seen in keratoconus. So we are nearly done with 4 MCQs here. Chalcosis, siderosis, KF ring seen in Wilson's disease, and Fleischer ring seen in keratoconus. All right. Okay. Now next, moving over to the third question. A child with a history of malnutrition is examined and the following image is seen. What is the most likely diagnosis? Can you appreciate what is this? So if you have ever attended my regular class, so I always used to show some real patients so that it becomes easy for you to connect the dots. But here, since this question is slightly on the difficult size, so I want all of you guys to see one patient which will clear your doubt, है ना? So check this out. So the image is almost similar to our this patient. Can you appreciate? So now you will appreciate something. What is this? What is this? What is this bulging eye which you see? बताइए कौन सी साइड से आ रही है लाइट? Okay. अब कहां से आ रही है? See, check out the cornea, whether it is clear, it is hazy, or what it is looking like. I hope. Now, what is this? So there is bulging of the cornea. So this is almost similar to what? To this image, if you could appreciate it well. Now, can you connect the dots and let me know what can be the answer here? ध्यान से देखेंगे. So my idea is that you should be able to correlate the things. So okay, now can you appreciate? If I talk about megalocornea, I told you in the very beginning that we need to eliminate the option one by one. Megalocornea is big cornea. Big means how big? If the corneal diameter is more than equal to how much? 12 millimeter. Okay, but here let's take it is big cornea, but in megalocornea, cornea will be hazy or clear? It will be clear. So it is very hazy cornea. Let's say you are not able to make it out. So there is a technique by which you can remove the options one by one and ultimately reach upon the final answer. Okay. What about boophthalmos? If I talk about boophthalmos, so why would there be any history of malnutrition? No, na. So there will be history of watering. There is a typical triad of congenital glaucoma: watering, photophobia, and blepharospasm. This is typically seen in your congenital glaucoma, and in congenital glaucoma there is boophthalmos, which you don't see here. So 2 options eliminated. Even again I am repeating, if you don't know anything still, now your chances of taking the wild guess has increased to 50% of getting it correct. Okay, now corneal degeneration, anterior staphyloma. Now let's try to connect the dots. If there is history of malnutrition, so what will happen? There is something known as xerophthalmia. I hope you know it. Yes, there is a disease known as xerophthalmia, which is due to vitamin A deficiency. When there is vitamin A deficiency, you must have gone through the classification of xerophthalmia. So there is classification like X1, X1A, X1B, X2, X3, X4 and so on. So there is something known as conjunctival xerosis, which is due to deficiency of vitamin A, conjunctival xerosis, and there is something also known as corneal xerosis. Now if there is, let's say if there is corneal cirrhosis, that means drying of the surface of the cornea, so that will lead to the formation of ulceration. So vitamin A deficiency led to corneal cirrhosis, which led to ulceration formation. If there will be ulcer, so there will be sloughing of the superficial layers of the cornea, which will eventually get ruptured, leading to formation of pseudocornea, and the end product, if there is formation of pseudocornea, that is your anterior staphyloma. So this is how you connect the dots. This is how you connect the dots. Okay, all right, so this is a case of your anterior staphyloma. I have connected the history of malnutrition with that of formation of anterior staphyloma. Okay, all right. Now a young male complains of rhinorrhea, means watering, watery eyes, so watering from the nose, watering from the eyes, and itching. A clinical image is provided. What is the diagnosis? So if you would appreciate, these are typical form of papillae which you call as cobblestone papillae. Cobblestone papillae are there. Okay, and the patient is given a history of rhinorrhea, watering, and itching. Probably we are talking of some form of conjunctivitis, which is allergic conjunctivitis. Now which allergic conjunctivitis is this? So bacterial conjunctivitis? No, not at all, because in bacterial conjunctivitis you will not find cobblestone papillae, you are going to find follicles. If you could recall, follicles are seen in conditions of infection, while papillae are seen in conditions of allergy. So it is eliminated. Even trachoma, you will have follicles, but here these are papillae. In trachoma there will be other signs as well: bulbar follicles, pannus formation, entropion. Then there may be Herbert pits, which will be peripheral limbal scars. Okay, which is not seen here. You can appreciate that the cornea is pretty clear. There are no peripheral scars or something like this. Then there is angular conjunctivitis. Angular conjunctivitis is, you can appreciate, if this is the eyeball, this is the eyelid. Why it is known as angular conjunctivitis? Because of the inflammation of the conjunctiva at the angles. So this is the, let's say, medial canthus. This is the temporal canthus, nasal canthus or temporal canthus. So in angular conjunctivitis there will be inflammation of the conjunctiva at the angles, but you cannot see any inflammation at the angles. So even if you don't know anything about the history which is given, from which it is associated, you can simply go on for VKC. Mind you, in these sessions I am not only telling you the right answer, I am also telling you, even if you don't know anything, how you can reach up to the right answer by simply applying the rule of elimination. Okay, now because we are doing VKC, let's discuss another important MCQ. If instead of young male, if there is girl, if instead of rhinorrhea, watery eyes, and itching, there is a history of contact lens wear, what will be your answer? Yes guys, come on, keep answering. Of course I am sitting away from you remotely, but feeling is such that you are in my class right now, so you have to keep answering. If the examiner says a girl with the history of contact lens wear comes with the following image, the image may be same, so what will be your diagnosis? No, 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 the same image. The same image means there is presence of papilla. If there is presence of papilla, what will be your answer? It will be your GPC, giant papillary conjunctivitis. Sometimes on seeing on the image, it may not be easy for you to differentiate between vernal keratoconjunctivitis and giant papillary conjunctivitis because of the same appearance of papillae, which is cobblestone papillae or giant papillae. On the image it may be difficult, so you have to focus right on the history. If young male, itching, rhinorrhea, allergy, अब हो रहा है सर, देखिए सर, एक बार देखिए, आप देखिए, आ गया सर? तो देयर वाज सम इशू विद द ओबीएस, राइट? तो अब उसमें आ जाएगा, मैं करूँ सर कंटिन्यू आगे? ओके ओके ओके, डन, ओके डन, ओके डन, हो गया, डन, थैंक यू थैंक यू थैंक यू। ऑलराइट गाइस, there was some issue with the streaming. Now I think, is it clear? एक बार बताएंगे, एक बार बताइए. Now is it fine? Yes 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 everyone, is it fine? Please confirm me once. Audio video clear? एक बार बताइए. I am waiting for your responses. एक बार बता दीजिए जल्दी जल्दी. Waiting for your responses. Okay, your knowledge to know, good, very beautiful username you have. Okay, let me see. Yes, all right, चलो चलो जल्दी से स्टार्ट करते हैं. लेट्स स्टार्ट अगेन. सो वी वर एट स्यूडोमोनास. सो आई वाज टेलिंग यू. ओके गाइस, आई नीड योर एनर्जी बैक. कम बैक, जल्दी आ जाइए. all right, so you have understood. So I was telling you about pseudomonas, which is most common infection associated contact lens users. Okay, now coming over to the most common cause of infection in contact lens users who have the ability or who are swimming in pond with contact lenses on. Who are swimming in pond, history of swimming with contact lens on. This is first thing to know about, contact lens on. Second, who are washing their contact lenses in tap water. Then boys and girls, mind you, it will not be your pseudomonas, it will be your acanthamoeba. Most of you guys were answering acanthamoeba. So I am mentioning it here that for acanthamoeba to be a causative organism, it should have a history of swimming in pond and washing contact lenses in tap water. All right, now which is the treatment of choice for recurrent pterygium? So if we are talking of recurrent pterygium, recurrent, you already know that if we will simply go for Bayer sclera technique, you simply excise the pterygium, right? So there are chances which is 70 to 80% recurrence, which we don't want. Patient is paying you nearly 20,000 rupees for pterygium. You would not want patient to come back to you and say, डॉक्टर साहब आपने 20,000 रुपए ले लिए, 5 मिनट का प्रोसीजर करा, अब दोबारा हो गया, आप क्या दोबारा पैसे लोगे? बच्चे की जान लोगे क्या? तो समझो that we don't usually go for Bayer sclera technique. हाँ, अगर पेशेंट ने 4-5 हजार दिए फिर आप कर सकते हो कि चलो कोई बात नहीं, अगली बार खाता पूरा कर लेंगे. नो, आई एम जस्ट जोकिंग. सो व्हाट आई एम टेलिंग यू इज, इन Bayer sclera technique you usually go on for recurrence which is 70 to 80%, but we don't want that to happen. So the best is you remove the pterygium and you take the patient's own autograft and put it on the place of the pterygium. So what will happen? This extra conjunctival autograft is going to act like a barrier which will prevent the further proliferation of the conjunctiva from the nasal side onto the cornea. So the answer is conjunctival autograft. But let me just show you one interesting thing so that it becomes easy for all of you to understand. तो देखेंगे पहले, ये देखिए. So this is how it is done. This is just to make you understand. So this is your pterygium surgery. I'm quickly going to run it in 1.5x. So this is grade 2 pterygium. So it is your previous year question, boys and girls. ध्यान से देखेंगे. So grade 1 is when it is just 0 to 2 millimeter on the cornea. Grade 2 is when it is 2 to 4 millimeter on the cornea. And when it is more than 4 millimeter upon the cornea, you call it as grade 3. Okay, I hope you have understood. So what I am doing is I am cutting it. Okay, so once I remove it and I leave the sclera as such, you call it as Bayer sclera technique. But it has got a very high recurrence rate. So I would not want this to recur. So I am going to measure the defect which has been created after excising the pterygium. Yes, Then I am going to take the same dimensions of the conjunctiva from the superiotemporal side by the same method, and then I am going to take it and place it on the nasal side. It will prevent the further proliferation of the nasal conjunctiva upon the cornea. Have you understood? This is your autograft. Auto means the same person's graft. Xeno means अगर इंसान की आंख में कुत्ते का कंजंक्टिवा लगा दिया, बिल्ली का कंजंक्टिवा लगा दिया. एलो इज अगर एक बंदे की आंख में किसी और बंदे का, ह्यूमन बीइंग का कंजंक्टिवा लगा दिया. सो यू शुड नो ऑटोग्राफ्ट, एलोग्राफ्ट, xenograph. I hope it is well understood. Okay, all right, okay. So now in the end, what you are going to do, you are going to put the graft and you are going to put a glue. Glue means there is medical grade glue. वो 5 रुपए की फेविक्विक मत खरीद के ले आना और लगाने लग जाना, चिपकेगा नहीं. Okay, all right. So you have understood and the answer is pretty straightforward. As per the question, it is your conjunctival autograft. Okay, all right. Now moving ahead. So next is a patient with a vision of less than 3/60 and more than 1/60 in his better eye. Which type of blindness does he has? So there is a criteria, and as per the criteria there is low vision. So as per low vision, if the vision is less than 6/18, less than 6/18 to 6/60, so you call it as low vision. Then economic blindness is when the vision is less than 6/60 to 3/60. Then there is social blindness when the vision is less than 3/60 to 1/60, and there is manifest blindness when the vision is less than 1/60, and there is finally your absolute blindness when there is PL negative, means the patient cannot even sense when you throw the light into the patient's eye. That is your PL negative. Now you know what should be the answer. The answer is social blindness. But since we are talking of blindness, it is very important to understand one of the most controversial topics in regards to blindness. Can you tell me the definition of blindness? Yes, everybody. कोई बता पाएगा what is the definition of blindness? Blindness is when the visual acuity is visual acuity less than 3/60. Mind you, in better eye, there are 3 keywords: visual acuity 3/60, in better eye, with best possible correction. Now one is visual acuity, another is visual field. If visual field is less than 10 degrees, it's one and the same thing. As per the criteria, you will keep it under the definition of blindness. So this form of definition, whatever I have told you, this definition is as per World Health Organization. Have you understood? Yes, understood? Yes or no? Yes. Now, but as per NPCB-VI, NPCB-VI is National Program for Control of Blindness and Visual Impairment. What is the definition? It is less than 3/60 or same less than 10 degree in better eye. So till now it is same. Now it changes everything. Now with best possible correction in WHO here, with available correction, if it is in the option available correction, or you can say presenting visual acuity. So I am going to tell you what does it means. Presenting VA means presenting visual acuity. See, I am sitting in my peripheral OPD. A patient has walked in. So I am asking the patient to read the letters on the Snellen's chart, right from top to bottom. So he started to read. Okay. Now he starts reading A, X, O, H, T, V like this. Now his vision is, let's say, less than 3/60. If I start to correct his vision by placing the glasses -1, -2, -3, -4, or +1, +2, +3, +4, if his vision improves, then as per WHO, he is not blind. Let's say on putting the glasses, his vision has now become 5/60. So as per WHO, he is not under the definition of blindness. But as per NPCB and VI, the patient has come, the patient has started to read, and simply by covering the one eye, if he starts to read, the vision is 2/60. So it is presenting visual acuity. I am not trying to give any glasses. Yes. So in that case, you will tag the patient as blind as per NPCB-VI. But maybe if you give glasses to the patient and his visual acuity improves to till 5/60, let's say, then as per WHO, he will not be considered as blind. Okay. All right. So I hope you have understood. Yes. And Dr. Mohammed, taken. Noted. I'll take care. All right. Okay. Done. So I hope you have understood. Now coming over to the next question. A farmer is hit by a leaf or vegetative matter in his eye few days back. He visits IOPD with pain and photophobia. What is the most likely cause? So we are talking of a typical injury, and that injury is your organic matter injury. You know that any organic matter injury history, if it is given in the question, you will think of one type of keratitis, that is your fungal keratitis. No doubts about it. Single liner question with just one keyword, organic matter injury. So it cannot be herpes simplex viral keratitis. It will not be acanthamoeba keratitis. It will not be bacterial keratitis. The answer will be fungal keratitis. But mind you, in fungal keratitis, the signs are more than symptoms. But because we are reading about fungal keratitis, your previous year question says that the typical feature of fungal keratitis is your satellite lesions. Now what are satellite lesions? So satellite lesion is, this is the cornea, and there is one main lesion. So this is your main lesion, but there are small lesions which will be surrounding the main lesion. So you call it as satellite lesions. And there will also be presence of hypopyon. Hypopyon is pus in the anterior chamber. This pus will be non-sterile because this pus will be having fungus. And another important point I want to tell you, which is asked in your previous year question, that the margins of fungal keratitis will be non-defined margins or fluffy margins. Simple as it is, fluffy margins. So my dear doctor, panic shield ulcer is seen in atopic conjunctivitis, not in fungal keratitis. And mind you, you have to differentiate between shield ulcer and fascicular ulcer. Shield ulcer is seen in, I'll just write it here since this is your query. Shield ulcer is seen in atopic or even vernal keratoconjunctivitis, while fascicular ulcer is seen in flick-tenular conjunctivitis. Okay. Now coming over to the next question. A girl with ptosis when eats food and sips fluid, her ptosis is decreased. What is the most common cause? So I am going to show you the patient and you will look out for your own self, and then you will let me know what do you think, what can be the most common cause. Check this out. Can you tell me? Check this out. Now can you appreciate the left upper eyelid? देख पा रहे हैं? All right. So what is this? This is your Marcus Gunn jaw wing syndrome. Okay. And this Marcus Gunn jaw wing syndrome is placed under special form of ptosis, boys and girls, and that is your complicated ptosis. Okay. I am writing it here for you. Marcus Gunn jaw wing syndrome. All right. So the answer is D. It is not mechanical ptosis. Mechanical ptosis is when due to the upper lid tumor, maybe large chalazion, there will be drooping of the eyelid due to gravitational effect of the large mass. है ना? Horner syndrome is due to paralysis of sympathetic fibers, and in Horner syndrome there will be just 2 millimeter of the ptosis which will be there. Okay. Blepharophimosis syndrome is when there is very small interpalpebral aperture. Okay. All right. Now, which of the following technique is gold standard for measuring IOP? I always say in my classes, gold for gold, gold for gold. It is Goldman's applanation tonometer, because applanation tonometry is better than indentation tonometry. Schwartz tonometer is a form of indentation tonometer. Indentation tonometer. Pulse air tonometer is used for screening purposes. Screening purposes in the form of a tonometry which is non-contact tonometry. Non-contact tonometry, while tonopen is used for edematous corneas, edematous or scarring, and it is in fact the tonometer of choice in children. बच्चों में tonopen is very very helpful. Okay, now a newborn child presents with watering photophobia. We have done na watering photophobia, blepharospasm. On examination, following images seen. What is the diagnosis? Can you appreciate the size of the eyeball? It is relatively big. Let me just show it to you. एक बार दिखा देता हूँ आपको. देखिए ऑलमोस्ट सिमिलर सी इमेज आपको दिखेगी मेरे इस पेशेंट में. तो ये देखिए, कुछ देख पा रहे हो दोनों आंखों में? आर यू एबल टू अप्रिशिएट द डिफरेंस? द राइट आई एंड द लेफ्ट आई. The size of the left eyeball is increased. That is your boophthalmos. So we are talking of boophthalmos, which is a feature of your one disease in boys and girls. That is your congenital glaucoma. No, it's not megalocornea, my dear Dr. Panic. If I talk about megalocornea, there will not be any associated features like watering, photophobia, and blepharospasm. They are typically, this triad is typically seen in congenital glaucoma. So we will think on the grounds of congenital glaucoma only. Okay, ji? Alright, congenital cataract, no, because in congenital cataract you are going to see leukocoria, white pupillary reflex, but you don't see white pupillary reflex. There should not be any watering. There shouldn't be any photophobia. Megalocornea, no, I have already told you. Congenital dacryocystitis, there can be watering, there can be photophobia, but in dacryocystitis there must be a swelling on the nasal side which is absent here. So this is how you need to connect the dots. Okay. Yes, Dr. Ashik, nice name. So half striae are seen in congenital glaucoma. The sclera is slightly bluish in color. Okay, good. A lady suffers sudden painful loss of vision in her eye with worsening of pain during eye movements. If there is worsening of pain during eye movements and sudden painful or even in some cases painless loss, RAPD is present. You know, whenever RAPD is present, you have to think of the afferent pathway which is formed by the optic nerve. You know that if I am talking of the pupillary light reflex, optic nerve forms the afferent pathway and oculomotor nerve forms the efferent pathway. In cases of RAPD, it is the optic nerve which is involved. So CRVO, we are talking about central retinal vein occlusion. RAPD may be present in CRVO, but there will not be worsening during the movements. So eliminated. Papilledema, it is disc edema, but it is not associated with sudden painful loss of vision. So in papilledema, the vision is usually not affected and there is no pain. In fact, in papilledema, due to raised intracranial tension, there will be intense headache, overall headache, which will be non-dependent on the position. Retinoblastoma, no, retinoblastoma is not associated with the pain. It is not associated with sudden painful loss of vision. So the answer is optic neuritis. Very good. It is optic neuritis. All right. I hope you are enjoying the session. We are eliminating the options one by one. What could be the site of lesion in person with macula sparing homonymous hemianopia? So macula sparing homonymous hemianopia is like this. Can you appreciate? So there is typical sparing of the macula. So can you appreciate if there would have been a visual field defect in both the eyes like this, you will simply call it as left homonymous hemianopia. This is left homonymous hemianopia. Okay, and this form of hemianopia is seen in patients with optic tract lesion. Optic tract lesion. Okay. Now, if there is macular sparing, that actually tells me that this defect lies in the occipital lobe. Okay, so the answer is occipital cortex. But why there is macular sparing in homonymous hemianopia? Because the macular fibers which are being interpreted by brain, they lie deep in the occipital lobe. Then you'll say, sir, okay, they are lying deep, but why they are spared? They are spared because in cases of एंड इनफैक्ट इन द ऑक्सीपिटल लोब, अगर ऑक्सीपिटल लोब में कोई क्लॉट आ गया है तो आइडली तो ऑक्सीपिटल लोब में जितने फाइबर्स आ रहे हैं वो सारे खत्म हो जाने चाहिए, सारे ऑप्टिक ट्रैक के फाइबर्स खत्म हो जाने चाहिए. अगर राइट पार्ट ऑफ द ऑक्सीपिटल लोब में क्लॉट आया तो राइट ऑप्टिक ट्रैक के फाइबर्स खत्म हो गए. अगर राइट ऑप्टिक ट्रैक के फाइबर्स खत्म हो गए तो पेशेंट को तो लेफ्ट होमोनिमस हेमिएनोपिया होना चाहिए. बट व्हाई देयर इज मैकुलर स्पेयरिंग? बिकॉज द मैकुलर फाइबर्स इन द ऑप्टिक ट्रैक दे एंटर डीप इनटू द ऑक्सीपिटल लोब such that when there is infarct of one side of the occipital lobe, the fibers which are deep, they are being supplied by another artery. तो infarct occipital lobe में कब होगा? जब posterior cerebral artery में क्लॉट फंसेगा. लेकिन जो मैकुलर फाइबर्स हैं, जो हम मैकुलर स्पेयरिंग की बात करें, मैकुलर जो फाइबर्स हैं वो ऑक्सीपिटल लोब में इतनी डीप चले जाते हैं कि वहां पे एक और ब्लड सप्लाई होती है जिसको बोलते हैं मिडल सेरिब्रल आर्टरी. तो इवन इफ देयर इज सडन ब्लॉकेड ऑफ पोस्टीरियर सेरिब्रल आर्टरी, देयर इज स्पेयरिंग ऑफ मैकुलर फाइबर्स बिकॉज दे एंटर डीप इनटू द ऑक्सीपिटल लोब व्हिच इज सप्लाइड बाय मिडल सेरिब्रल आर्टरी. समझ में आया जी? मिडल cerebral artery. Okay, all right, so that is why there is macular sparing. Okay, a man suffered a trauma in his right eye with a punch. Okay, which of the following will most commonly occur in this case? So punch happened. So punch is which form of trauma? Blunt trauma or penetrating trauma? It is blunt trauma. Now, which is the most common orbital wall which gets fractured in blunt trauma? It is the inferior orbital wall fracture, not medial. Of course, medial wall we have got one bone, that is your lamina cribrosa, one bone which is lamina cribrosa, and this is the thinnest wall. But in most of the blunt trauma cases, it is not the thinnest wall which gets fractured, it is actually the inferior wall which gets fractured. So hence the answer, your previous year question along with the x-ray. A patient presented with painless loss of vision with the given fundus findings, what is the diagnosis? So can you appreciate, let me just zoom it a little bit, so you will appreciate that there is a dot, there is a blot, there are soft exudates. I am writing it here again. So this is your soft exudate, and these are your dot and blot which is pointing towards one typical form of diabetic retinopathy. You call it as non-proliferative diabetic retinopathy. Had it been proliferative diabetic retinopathy, there would have been neovascularization, but you don't see neovascularization here. And what about CRAO? Had it been a CRAO, there would have been pale or milky white fundus. I repeat, pale milky white fundus because of the sudden cessation of the blood supply in central retinal artery. But it is not the case. Had there been CRVO, means sudden cessation of blood supply in the vein, so vein would not be able to carry the blood back, right? So there will be a typical splash tomato appearance. So you cannot see any of these. So the answer is NPDR, non-proliferative diabetic retinopathy. A 10-year-old child is diagnosed with amblyopia, okay, in one eye. All right, amblyopia in one eye. What will be the best treatment, or can you tell me what is the cause of amblyopia? Amblyopia is the decrease in vision without organic cause. That actually tells me that physiologically is absolutely okay, but why there is decrease in vision? Due to stimulus deprivation. So what is the cause of stimulus deprivation? So first and foremost, treatment. What will be the treatment? So treatment is observation. No, in observation it will not help. Penalization, occlusion, or none of the above? The answer is occlusion. What is happening in amblyopia is that if the child is having congenital cataract, if the child is having congenital ptosis, if there is anisometropia. Anisometropia is, what is anisometropia? Please write with me. This is your another PYQ. If I am talking of anisometropia, it is the difference in the refractive error of two eyes. I repeat, anisometropia is difference in the refractive error or difference in refractive power of two eyes. Okay, what do you understand by significant anisometropia? Significant anisometropia is when the difference in the refractive power of two eyes is at least 2.5 or more. Significant is if it is at least 2.5 diopter or more, so more than equal to. Okay, so this is your significant anisometropia, and in fact anisometropia is most common cause of amblyopia. So because from one eye the child is not able to see properly, with other eye the child is relatively able to see properly. So what the brain would do, brain would suppress the growth and development of the eye which is perceiving the hazy vision. Okay, so because the brain thinks that this eye is not helping the body anyway, so the brain will suppress the vision which is being provided by this eye, because this vision is anyway not clear, it is blurred. And how will you treat? You simply go on for patching, occlusion. Occlusion of which eye? Occlusion of normal eye, not the abnormal eye. If you will occlude normal eye, you are forcing the brain to use abnormal eye. So when the brain starts to use abnormal eye, because anyway the patient is not seeing from the normal eye, so as a result the brain is forced to restart the growth and development of this eye which was previously being suppressed by the brain. Okay, all right. Next is a lady presents with pain, proptosis and loss of vision. Okay, on examination the given image is seen. What is the diagnosis? Can you appreciate? So what are the features? So there is lid edema. Yes, you can appreciate. There is conjunctival congestion. Conjunctival congestion is there. Conjunctival chemosis. What is chemosis, boys and girls? It is the swelling of conjunctiva. And here also you can see that there is a little bit of proptosis as well. So all of these features are going in sync with that of one disease, but let's eliminate the options one by one. In preseptal cellulitis, there is no proptosis, but there can be lid edema, conjunctival congestion and chemosis. Okay, so it is eliminated. In blepharitis, there will not be conjunctival chemosis. There will not be conjunctival congestion, because blepharitis is inflammation of the eyelid. There will be lid edema, but there will also be not presence of proptosis. Proptosis will be typically absent, because blepharitis we are only concerned about the eyelids, inflammation of the eyelid. So that is also eliminated. Stye is hordeolum externum, and this is acute tender nodule at the lid margin. There is no proptosis, no conjunctival congestion, no conjunctival chemosis. So the answer is orbital cellulitis. Clear? Okay, चलिए आगे चलते हैं. A patient is presented with complicated cataract and the findings on the slit lamp are as shown in the image. तो देख पा रहे हैं, you can see the opacity here. Very good. Which type of cataract is present in this patient? If you are not able to appreciate the image which is provided, still based on the keywords which are given, you can easily mark the right answer. So they have given a keyword which is complicated cataract. Can you tell me the most common type of complicated cataract? The most common form of complicated cataract is posterior subcapsular cataract. Okay, now they have given you an image which, let's say, you are not able to interpret. Just underline complicated cataract, and then most common cataract will be posterior subcapsular cataract. Mind you, oil drop cataract is seen in galactosemia, which is your metabolic cataract, not complicated cataract. Rosette cataract is seen in blunt trauma, which is a traumatic cataract, not complicated cataract. Senile cataract is another form of cataract which is related to age. So even if you don't know anything, you can still eliminate the options and can reach up to the final answer, which is A, which is PSC, posterior subcapsular cataract. Okay, a 60-year-old diabetic male present with a history of breathlessness, pyrexia, tachypnea and malaise. RT-PCR report came out to be positive for SARS-CoV-2 virus. On day 10, the patient develops bilateral orbital swelling. The right eye proptosis. What could be the causative organism? You already know the answer. The answer is mucor. Remember, you must have heard during COVID times that there is black fungus, black fungus, black fungus. That is nothing but mucor. So the answer to this question is pretty straightforward. It is mucor. Okay, good. This question was your FMG, was in your FMG exam during COVID times only, 2021, है ना? So this was asked. So in which of the following VY procedure is performed? So one is VY. There is another procedure which is Z-plasty. Easy way to remember is in ectropion you go on for alphabets. So it is ectropion. But if we are doing an ectropion, the entropion based surgeries may be asked in due course. So let's just jot down the names. It is Jones procedure, it is Bix procedure, and Quickert's procedure. But if I talk about the entropion, ECTRO, ectropion means outward rolling of eyelids. Entropion is inward rolling. I am not saying rolling of eyelashes. I am saying inside or inward rolling of eyelids. That is entropion. Ectropion is outward rolling of eyelids. So for ectropion you go for VY operation and Z-plasty. A 10-year-old boy with intentional tremors, okay, hepatosplenomegaly, CNS changes are also there, and he has come to OPD. On examination, the slit lamp shows this peripheral golden brown colored ring. So we have done this question before, the second question in fact. So this is your nothing but KF ring, and you see that KF ring is seen in Wilson's disease, whose typical history is given in the question, and KF ring consists of copper deposition in the Descemet's membrane of the cornea. Okay, let me take it a little higher. So what will be the serology in Wilson's disease? This is also very, very important. So there will be increased urinary copper, there will be decreased serum ceruloplasmin. This was also asked in your previous year examination, and decreased serum copper. ठीक है, ये तीन चीजें important है. तो it was asked which of the following is false about Wilson's disease. तो ऐसे चार metabolic पैरामीटर्स दिए हुए थे जिसके बेसिस पे आपको एक को सेलेक्ट करना था. अब आप बोलोगे सर सीरम सेरुलोप्लाज्मिन, सीरम कॉपर कम क्यों है? इसलिए कम है बिकॉज कॉपर इज 99% प्रोटीन बाउंड. टू प्रोटीन बाउंड मीन्स टू सीरोप्लाज्मिन. सो सेरुलोप्लाज्मिन is decreased because of the mutation in the gene which is ATP7B, right? So because there is less of ceruloplasmin and copper is transported in the blood via ceruloplasmin only, so naturally the serum copper will be low. All right, yes. So S in SAFE strategy of trachoma stands for, I repeat, S in SAFE strategy is surgery. But if I take it a little higher, so which surgery? It is trichiasis surgery. If trichiasis is not in the option, then you go on for entropion. Okay ji, you don't simply go for entropion if there is trichiasis in the option. What is A? A for antibiotic prophylaxis. Which antibiotic is used? That is your azithromycin. Okay. What is F for? It is facial hygiene. You have to maintain good facial hygiene. E for your environmental sanitation. Okay. All right. So this all you should know. अच्छा, क्या आप मुझे बता सकते हैं when do you want to initiate the SAFE strategy, or randomly you are going to start the SAFE strategy in the community? Only when the prevalence of trachoma in the community is more than equal to 10%. Then you start with safe strategy. Now you'll say, okay sir, pata lag gaya. How do we know whether the prevalence is 10% or more or not? You simply go for screening for the most specific diagnostic feature of trachoma, that is presence of bulbar follicles. That is presence of bulbar follicles. Bulbar follicles are diagnostic of trachoma. Bulbar follicles in the age group 1 to 9 years. If it is more than or at least equal to 10%, like you have taken random sample of 100 children from 1 to 9 years of age, and you start everting the upper lid, or you start seeing the bulbar conjunctiva. That is more important. Bulbar conjunctiva is diagnostic. Of course there will be follicles in the upper lid, lower lid, but yes, upper lid more specifically, not in lower lid that much. So you will go on for seeing the bulbar follicles, which will help you diagnose it as trachoma, because that is the specific feature. So out of those 100 random children, if at least 10 have bulbar follicles, you will immediately start with safe strategy in the community. ठीक है जी? Okay. Now a 34-year-old male working as welder came with complaint of pain, redness and watering eyes. The image is shown. What is the management? So you can appreciate what is this. Can you appreciate something here? So what is this? बता पाएंगे क्या लगा आपको? तब तक मैं आपके लिए कुछ तैयारी करता हूँ किसी चीज की. So check this out. Almost similar to this. यही है, सिमिलर है ना? चलो अब मैं क्या कर रहा हूं वो आप भी देख लीजिएगा. What I am doing, the exact same answer you will pick from the given options. So what I am doing, so there was foreign body, so I am having my 26G needle, and under the slit lamp view, of course there will be some magnification, I am taking the foreign body. So I have put a topical anesthetic drop on the surface of the cornea, because I don't want the patient to feel uncomfortable and start blinking, right? So this is what I am going to do. I am going to remove the foreign body. Okay, so this is another video. So you could see that there is a very small foreign body. So if you could see, let me just show you. All right, so this is the foreign body which I have removed. So you will see the foreign body which I have removed. Okay, all right, can you see the foreign body? So best is to remove it with the help of a needle, and the most comfortable needle to remove the foreign body is your 26G needle, because that is relatively very small. Okay, all right, so this is the answer. We have seen the real patient. What is the position of lacrimal sac in the body? So you know, don't confuse your lacrimal gland with that of lacrimal sac. Lacrimal gland is on superior temporal side, while lacrimal sac is on nasal side. So the answer will be your medial wall. Okay ji, all right. Now a patient, no, it's not roof, my dear friend. On the superior temporal part of the orbit, it is lacrimal gland, but they have asked about lacrimal sac. Lacrimal sac is nothing the other name of nasolacrimal sac, which actually drain the tears. Lacrimal gland, it produces the aqueous component of tear film, hai na? Okay, so a patient had diabetic cataract since few months. Which compounds are accumulated in lens responsible for cataract? So diabetic cataract, two compounds, sorbitol plus fructose. If this is not in the option, go for only sorbitol. If this is not in the option, go for only fructose. Okay, all right, coming out to the next question. Which of the following synergistic muscle of right lateral rectus? अब समझेंगे, इसमें आप बहुत लोग गलत करते हैं. देखो प्यार से समझेंगे, ध्यान से समझेंगे. So if I am asking you about the synergistic muscle of right lateral rectus, so what is the action of lateral rectus? So lateral rectus lies on the lateral side. If I abduct the eyeball, so that is via contraction of right lateral rectus, है ना? So I know that synergistic muscle will be the muscle which will help the lateral rectus in abduction. So any muscle in my right eye, because they have asked about right lateral rectus na. So the muscle which is helping the right eye to abduct will be synergistic to right lateral rectus. Now out of the given muscles, which muscle will be assisting the right eye to abduct? तो देखते हैं. So because it is given right, so simply remove left options. If you remove the left option, by that only you are able to get the right answer. Otherwise you also know that obliques are abductors and recti are adductors. Superior are intorters and inferior are extorters. Okay, so they have asked about right lateral rectus, which means abduction. So out of which it can be oblique, superior oblique and inferior oblique, and more specifically it will be right inferior oblique because they have asked about right lateral rectus. Okay, now a patient presented with loss of vision in both eyes on same side with central sparing. It is one and the same thing. Loss of vision in both eyes on same side with central sparing. So it is nothing but homonymous hemianopia with macular sparing, which we have just done. Now, xerophthalmia causes dry eyes due to deficiency of which of the following vitamin? This also we have done. It is actually vitamin A. Mind you, the classification of xerophthalmia is very important. Now, can you tell me the dose which you give if the age of the infant is 0 to 6 months? 0 to 6 months. So what will be your dose? If it is 6 to 12 months, what will be your dose? And if it is more than 12 months, what will be your dose? 0 to 6 months, 6 to 12 months. Can anyone tell me? 0 to 6 पहले बताएंगे. पहले 0 to 6 बताइए. देखता हूँ किसको आता है. Yes, this is something extra. 0 to 6 you are, or I am asking about oral dose. Not, yes, very good. 5K 50,000. So 50,000 international unit. Okay, 6 months to 1 year. Yes, 6 months to 1 year बताइए. 1 lakh. Yes, 1 lakh international unit. Okay, 0 to 6 months, 6 to 12 months. Okay, 1 lakh or more than 12 months. So it is 2 lakh international unit. All right, and it is given on 0, 1 and 14 days. Okay, that you all should know. 0 to 6, 6 to 1 and more than 1 year. And I am talking of oral, but if you give intramuscular, so you know intramuscular will have better bioavailability, so you will divide oral by 2. That is your intramuscular dose. Got it? Chalo, good. I am glad that you are very well prepared for the upcoming FMGE exam. Okay, a 70-year-old male comes with decreased vision. Okay, whenever you read the question, you just keep on highlighting, you just keep on noting down the keywords. So decreased vision is there. 70-year-old male. Okay, he had sclerotic changes of the nucleus. Retina is within normal limits. So there is just the sclerotic changes in the nucleus. Sclerotic means the patient's nucleus part of the lens is having more and more insoluble proteins. So which is nothing but cataract, hai na? If there is nuclear cataract, because they have specifically mentioned about the sclerotic changes in the nucleus, in nuclear cataract there will be index myopia, you already know that, but index hypermetropia will be seen in cortical cataract. Now many of you would say, sir, what is presbyopia? Presbyopia is not associated with any disease. It is physiological decrease in accommodation. This is physiological decrease in accommodation with age. Decrease in accommodation with age. More specifically after 40 years. After 40 years. So what happens is, you must have seen your parents, your grandparents who are not wearing spectacles as such, but when they read newspaper, when they watch anything on their mobile phone, they tend to wear spectacles. Why is it so? Because of presbyopia with age. So the power of the eye to focus on the near objects is constantly decreased. Why it is decreased? Because the increasing power of the lens, which happens while you focus on the near object, the increasing power of the lens, it does not increase after 40 years of age because of the sclerosis in the lens, because of the loss of elasticity of the lens, because of the weakening of the ciliary muscles, which causes accommodation. Okay, so I hope it is clear. I have told you. So physiological loss of accommodation, the function of accommodation is to be able to see near objects clearly. Now what is index myopia? Index myopia is when there is increased cataract or increased deposition of insoluble proteins in the lens. So lens will become very thick. When the lens becomes thick, lens refractive index increases and lens की power भी तब बढ़ जाती है. I again repeat, when there is nuclear sclerosis, nuclear sclerosis means deposition. So this is the lens. I am going to explain you, Dr. Ahmed, don't worry. So this is the lens, this is the retina, this is the cornea. Normally the image is being focused on the retina, okay, normally when the lens is clear, when the lens is transparent. But when there is thick nucleus due to insoluble proteins, nuclear sclerosis is the very initial stages of cataract formation. So there is nuclear sclerosis. Now because the lens has become thick in the center, so there is change in the refractive index of the center of the lens. This is the nuclear part, okay. And overall there is increase in the power of the lens, and you know that power is inversely proportional to focal length. Means more is the power, less will be the focal length, less will be the power, more will be the focal length. Now because of the increase in the power of the lens, the focal length will be small, and now the rays will be focused not on the retina but in front of the retina. When the rays are focused in front of the retina, you call it as myopia. But here this myopia. Alright guys, now is it clear? Ab theek ho gaya. There was some again technical issue. Alright गाइस, देखेंगे एक बार. ठीक हो गया? देखिए एक बार. ठीक हो गया तो बता दीजिए एक बार मुझे. सो सॉरी, आई डोंट नो व्हाट्स हैपनिंग टुडे. Yes. Okay, wonderful. So we can proceed forward. A 29-year-old child is diagnosed with anisometropic amblyopia in one eye. What will be the best treatment? And you know, most common cause of amblyopia is anisometropia. Now whenever you treat amblyopia, first you need to treat the underlying problem due to which amblyopia happens. So here it is anisometropia. Anisometropia I have already explained to you. It is difference in the refractive power of two eyes. First you will correct anisometropia by giving refraction. Once the patient's vision is 6/6, then you will go for occlusion. I hope it is clear. So don't mark simply occlusion right on seeing it as the A option. So you have to screen all the options one by one, and the best option, if refraction with occlusion was not in the options, then you would have gone for occlusion, no doubt about it, boys and girls. But right now, because refraction is there, and you know anisometropic amblyopia, and anisometropic amblyopia means difference in the refractive power of two eyes. So the answer is not A, it is C. Clear? Okay, now moving ahead. A 3-year-old boy comes to IOPD with no vision in one eye. Okay, enucleation is planned. What is enucleation? Enucleation is removal of the eyeball. It is removal of the eye. Which gene mutation can be seen in the child? So you know that CYP1B1 gene is associated with congenital glaucoma. Okay, CRIC gene is associated with congenital cataract. Okay, and RB gene is associated with retinoblastoma. These three genes are very important with respect to your ophthalmology. So congenital cataract, why you will go for removal of the eye? You will simply remove the cataract and implant the artificial IOL. Congenital glaucoma, so you will not remove the eye. There are multiple other things. So you remove the eye, you give this enucleation trauma to the patient. Of course it is going to be a mental trauma, na? If one socket is not having eye, it is a lot of mental trauma, cosmetic trauma to the patient. Of course, when the patient will grow up, you will not do it unless removing the eye is the only option you have, and you have this option as only option if there is a spread of a tumor which is retinoblastoma, which can metastasize and can be a threat of life to the patient. Congenital glaucoma, if there is raised intraocular pressure, even when the vision is down, the patient is not seeing anything, you will not go on for enucleation. There are multiple other methods, and you will simply go on for cyclophotocoagulation so that there is decrease in the IOP. But of course, glaucoma, once the vision is lost, you cannot restore the vision. But enucleation, no, not at all. Okay, so it is RB gene because that is the gene mutation which is responsible for retinoblastoma. A below image with diagnostic feature of cherry red spot can be seen in. So what do you see? So of course, this is a cherry red spot, and this is your pale and milky white fundus. Pale milky white fundus is there. And if we talk about CRVO, there will be splash tomato appearance of the retina, which is characteristic feature. If we talk about CME, which is cystoid macular edema, you will not see pale milky white fundus, you will not see cherry red spot, you will actually see the edema in the macula, So the answer you know is cherry red spot. It is CRAO, central retinal arterial occlusion. Okay, now the next question is, a 65-year-old male underwent cataract surgery 2 years back, now coming to you with complaints of decrease in vision since 3 months. What laser is used for his treatment? Can you tell me the most common late complication of cataract surgery? It is your after cataract. After cataract is when there is deposition of the epithelial equatorial cells behind the optic of the artificial IOL and the posterior capsule, and they will start to proliferate. So you simply rupture the posterior capsule with the help of a laser, and that laser is ND-YAG laser. Most common late complication, I am telling you, it is your after cataract. Very good. Okay, now identify the lesion. So under which light am I seeing this eye? Under blue light. This is your cobalt blue light. Okay, and the lesion that you see is actually green in color. So you know, whenever I want to illuminate the epithelial erosions on the cornea, I will stain the eye with a dye that is your sodium fluorescein. I again repeat, it is your sodium fluorescein which is going to absorb the blue light and going to emit the green light. And you can see that there is typical appearance of dendrites. Dendrites are branched endings with knobbed ends, so you can appreciate, and these dendrites are typically seen in viral keratitis. Which form of viral keratitis? Herpes simplex viral keratitis. But mind you, if you don't see knobbed ends, if you just see like this, these are not known as dendrites. In fact, they are known as pseudo dendrites. If I am asking you in which disease you see pseudo dendrites, you will go on for herpes zoster ophthalmicus. In bacterial keratitis, no dendrites. Fungal keratitis, no dendrites. In interstitial keratitis, there is no epithelial defect. So when you stain the cornea, there will be no staining, no epithelial defect. So no staining is there, because in interstitial keratitis, there is stromal involvement. There is no epithelium involvement because there is no physically erosion of the epithelium, so there is no staining. Mind you, this was also asked in your previous year exams. Okay, now Kopi nodules are seen in, so there are two types of nodules, Kopi nodules, Basaka nodules. These nodules are seen in specifically in granulomatous uveitis. This is also your previous year question, but the examiner is asking something else here, granulomatous uveitis, but the examiner is asking in which component of the eye is it seen? Is it the cornea, sclera, iris, retina, whatever? So the answer is typically straightforward. It is seen in the iris. Kope nodules, they are present. So if this is the iris This is the pupil. So they are present at the inner pupillary margins, just one step ahead. These are Cope nodules, and if they are present at the base, they are known as Basaka nodules. Basaka, how will you remember? Basaka at the base of the pupil, and they are big in size. So B and B. Cope, they are small. They are at the pupil margin, pupillary margin, inner pupillary margin. ठीक है जी? Okay. Now coming on to identify the image. This image has been again asked multiple times. Can you see a typical feature here? So I hope you can appreciate the typical feature here, and that is your what? And that is your tear drop sign. Very good, Dr. Panic. Very good, very good, very good. So it is your tear drop sign. Okay. आप देख पा रहे हैं, ये है आपका tear drop sign, and that is seen in orbital floor fracture. Okay. Now teardrop sign on X-ray AP view. Please write. Of course, we are going to share the annotated notes with you. So this annotated notes workbook is comprising of 120 MCQs, comprising of last 5 years. I have not repeated the questions which have been repeated in your exams. Otherwise, unnecessary, it will be a very big file. So 120 MCQs, I have repeated a few questions which like have been repeated like 5 times. I have repeated here 2 or 3 times to put more stress on such questions, because I don't want such questions to go wrong. So that is my idea. A 60-year-old man is being treated with anti-glaucoma. Okay. The drug and his bronchial asthma got worsened. So we are talking of some drug that can lead to worsening of glaucoma. What could be the possible cause? So you know, beta blockers can lead to precipitation of the asthma. Why? Because in bronchus there is B1 receptor and B2 receptor. B1 receptors, heart is one, so they are present in heart. B2, lungs are 2, so they are present in lungs, or you can say bronchus. Okay. Now if there is beta 2 blocking action of any drug, that is not going to allow the bronchus to dilate, because beta 2 agonist action leads to dilatation of the bronchus. So if you are giving beta 2 blockers specifically, it will not allow the bronchus to dilate, and in asthmatics this can be very, very deadly for the patient. So it can actually precipitate the asthma attack in asthmatic patients. So out of this, there is one drug which is a non-selective beta blocker, beta 1 plus beta 2, so which will be of course contraindicated. But there is another beta blocker which is betaxolol. That is not beta 2 blocker, that is beta 1 blocker. If we talk about a safe beta blocker in asthmatics, then you can go on for betaxolol, because it is your beta 1 blocker. All right. Now a lady presents with grade 2 pterygium. I have already shown you in a real patient video grade 1, grade 2, grade 3. So that was grade 2 to 4 mm on the cornea. What would be the best treatment in this case? So any pterygium, any grade, the best treatment will always be autograft, because if you will excise it with autograft, the chance of recurrence with autograft, I am telling, the chance of recurrence is just 0.01%. But Bayer sclera technique, simply excision means Bayer sclera technique. Bayer sclera, the chances of recurrence is nearly 80%. A patient presents with symptoms of floaters, flashes, and then curtain-like shadow. If you find curtain-like shadow, only one thing which should be there in your mind at that instant, and that is your retinal detachment. But let's eliminate the options one by one. In corneal ulcer, there will be pain, there will not be floaters, not be flashes, and no curtain shadow. In glaucoma, there will not be floaters absent, flashes absent, curtain absent, right? In retinal tumor, Why will there be any floaters absent, flashes absent, curtain absent? So the only option which goes well with all the given features is your retinal detachment. Now a child is being considered for IUL implantation. Okay, what should be kept in mind in such case while choosing IUL power? So whenever I want to operate the patient with cataract surgery, first and foremost thing that I need to do is to calculate the intraocular lens power which is to be implanted inside the eye once I will extract the cataractus. I think now it's done, sir. देखिए आप चेक कीजिए सर. आई थिंक नाउ इट्स डन. आ गया सर. चलो मैं करता हूँ. थैंक यू. All right guys, audio video all clear? Yes. So I have been told that there is some issue from the server side in OBS, the software which we educators use. So yes, can we proceed? Yes. So I was telling you about that a child is being considered for IUL implantation. So whenever I want to operate the patient for cataract surgery, I am going to calculate the power of the IUL, है ना? So that when I remove the cataractus lens, I need to implant the same power of the IUL. But for that, I need to perform two tests. One is keratometry, which is to detect the power of cornea, and another is A scan, which is the axial length of the eye. Now, when I am going to put both these values in a machine, the machine is going to apply one formula. What is the name of that formula? The name of that formula is your SRK2 formula, and the machine is going to tell me what power of the IUL is to be implanted in the lens after cataract extraction. Okay, so when you know that we are using the axial length of the eye for deriving the power of the lens, so suppose this is the cornea, this is the lens, and this is the retina. So we have removed this lens and instead we are going to implant this artificial IUL which is derived after calculating the axial length. But what happens in due course when the size of the eyeball is increased? So this is your R1 position, which is your right now retina position, and as the eyeball will grow, the R1 will reach here as R2. But since now this is not the natural lens, this is the artificial lens, so you had implanted the artificial lens here instead of the natural lens, which was cataractus, so it was to be removed. But the point of focus of this lens was as per the R1 only. But in due course the R1 is now moved backwards such that this R2 is the new position of the retina, but this lens will not grow. This is artificial one. So when the eyeball will grow, the point of focus which was earlier on the retina, as the retina will go behind, will go posteriorly, the point of focus will remain there only, such that it will be as the point of focus is in front of R2. When the point of focus is in front of the retina, which is the new place of the retina, which is R2 here, so that is your myopia. So while implanting the IUL in child after operating the patient for cataract surgery, it is very important to consider that there can be chances of post-operative myopic shift. आई होप यू हैव अंडरस्टूड. समझ में आया ना? तो मायोपिया का बहुत ध्यान रखेंगे, मायोपिया ना हो इस कारण हम लेते हैं कि अगर चाइल्ड की एज 0 to 2 years है तो हम 20% अंडर करेक्शन कर देंगे, 20% अंडर करेक्शन कर देंगे. अगर चाइल्ड की एज 2 to 8 years है ड्यूरिंग सर्जरी तो हम 10% अंडर करेक्शन कर देंगे. अंडर करेक्शन का मतलब ये है कि इफ द IUL पावर जो हमारे पास आई थी +20 डायोप्टर है, तो हम +20 डायोप्टर ना डाल के हम +16 डायोप्टर की IUL पावर यूज करेंगे, सो दैट व्हेन द R1 गोज फ्रॉम R1 to R2, सो द IUL जो हमने पहले डाला हुआ था उसकी पावर रिलेटिवली कम थी क्योंकि हमें फोकल लेंथ ज्यादा चाहिए. सो व्हेन द R1 position will get shifted to R2, the child will not have myopic shift, the child will become emetropic. समझ में आया? All right. Next is a child from poor socio-economic background presents with white foamy spots in both the eyes. What could be the reason? If we are talking of white foamy spots, you know we are talking of Bitot spots. Bitot spots are seen in vitamin A deficiency, and vitamin A deficiency is not given in the option, but you know, as per the classification of xerophthalmia, which is due to vitamin A deficiency, there is a term which is conjunctival xerosis. So what could be the reason? Of course, these foamy like appearance is due to conjunctival xerosis only, and hence is the answer. A 3-year-old boy presents with itching and red eyes, which is more in summer. Okay, there is also ropey discharge. This ropey discharge is known as Maxwell lion sign, and if there is any itchiness which is more in summers, we are thinking of spring catarrh. You will say, sir, kya baat kar rahe ho, spring catarrh or summer catarrh? It is more in summer. Yes, boys and girls, the name is spring catarrh, but it is more in summer. So this is your misnomer. The other name of spring catarrh is your vernal keratoconjunctivitis. This is your bilateral condition, and it is seen in males. So 3 years is given. Usually it is not seen in as young as 3 years. It is mostly seen in teenagers. These are all your keywords which can be asked. Okay, and Dr. Panic, you can get vitamin A oral dose, so you'll be fine, don't worry. A girl uses the contact lens shared by another person, okay, and develops painful red eye. Now, can you tell me, if I talk about the contact lens associated infection, what will be your answer? So it is just given that it is using the contact lenses which is from some other patient. So the answer is yes. Acanthamoeba? No, acanthamoeba is when you have a history of swimming in pond or washing the contact lenses with tap water. Candidiasis? No. Conjunctivitis? No, not at all. It is Pseudomonas. You all know it. Okay. Now next is, the following image shows the findings of a patient when retinoscopy done at a distance of 1 meter under homatropine. So I am going to plot what is given and then we will solve the equation. So check this out. देखते हैं यहाँ पे. So it was done from 1 meter and homatropine is used. If there is homatropine, you will deduct 0.50 diopter. Okay. So at x-axis, the neutralization was at 3.50 diopter. At y-axis, it was 2.50 diopter. But because it was done from 1 meter and homatropine was used, so you will do distance correction, you will do cycloplegic correction. So you will do -1 minus 0.50, -1 minus 0.50. So ultimately the value that you will get is your plus 1.00 after deducting plus 1.5 from plus 2.50, and at x-axis you are going to get plus 2.00. Now you have got the final equation, which is plus 2 at x-axis, plus 1 at y-axis. Now how will you actually prescribe the glasses? See, so one is you give plus 1 diopter sphere. Okay, now after giving plus 1 diopter sphere, this at y-axis will become 0. But at x-axis, because you require plus 2 diopter, but you have prescribed plus 1 diopter sphere, sphere is going to act both at x-axis and at y-axis. So you are left with extra plus 1 diopter, which is to be given at x-axis. Okay, but mind you, whenever you want to give any cylinder, you will always place the cylinder 90 degree to where it is required. So you require extra plus 1 diopter at x-axis. So you will place a cylinder, because cylinder is going to act only in one axis, sphere is going to act in both the axes. So you are going to place the cylinder of power plus 1.00 diopter cylinder, है ना, at what angle? 180 degree means at x-axis or at y-axis. I told you it will act opposite to where it is used. So if you will place it at 90 degree, it is going to act at 180 degree, which is at x-axis. So this is your one equation. You can deduce another equation. You can give plus 2 diopter sphere. Now this plus 2 has become 0, right? But here you require plus 1. but you have given +2 in the form of sphere, because sphere is going to act both at x-axis and at y-axis. Now you need to bring down from +2 to +1 at y-axis. So you will give -1 diopter cylinder at 90 degree or 180. You require this -1 power at y-axis. Now you will place it at 180 degree. Now you have got two equations. Based on the option, you can easily pick up the equation. So check this out. So what will be the glass prescription in this case? So first is +1 diopter cylinder at 90 degree. Okay, so this is the option which we need to take. +1 diopter cylinder at 180 degree? No. If it was -1 diopter cylinder at 180 degree, then of course it would have been correct. -2 diopter cylinder at 90 degree? No, not at all. +2 diopter cylinder at 180 degree? No. So the answer is A, which is +1 diopter cylinder at 90 degree. An elderly man who is one-eyed got punched in his only seeing eye. He presents with painful decrease in vision. What could be the cause? Painful decrease. So conjunctival hemorrhage? No. Why it would lead to decrease in vision? Of course there will be blood in under the conjunctiva, subconj hemorrhage, but it will not cause any decrease in vision. Sympathetic ophthalmitis? Sympathetic ophthalmitis will happen after 2 weeks to 2 months. The chances are just 1 to 3%. There will not be painful decrease in vision, so it is eliminated. Now you are left with optic neuritis and retrobulbar neuritis. So if we talk about retrobulbar neuritis, there is typically decrease in vision which is painful, and it is also associated with extraocular movements. I repeat, if on extraocular movements there is pain, you will think of retrobulbar neuritis first. Secondly, optic neuritis. If retrobulbar neuritis not in the option, go for optic neuritis, not to worry about it. But if it is there in the option and painful word is there, you will go on for retrobulbar neuritis. Optic neuritis may or may not be painful. Retrobulbar neuritis, it is definitely painful and is more associated with extraocular muscle movements. These are all the keywords. Yes, Dr. Ahmed, I think now you are clear because of the painful decrease in vision which is asked. Okay, now a child is brought by parents with white pupillary reflex. On examination, a cauliflower like mass with calcification is growing from the retina. Typically it is depicting of retinoblastoma. In calcification, white pupillary reflex is there, but cauliflower mass absent, calcification absent. Okay, eliminated. Retinal detachment, white pupillary reflex is there, but cauliflower like mass absent, calcification absent. Rhabdomyosarcoma is the malignant intraorbital tumor of extraocular muscles. So no white pupillary reflex, no cauliflower like mass, no calcification inside the eye. So this is how we have eliminated the other three options. A young boy suffered blunt trauma and develops monocular diplopia. What could be the reason? What is monocular diplopia? Monocular diplopia is when the patient will close one eye, when the patient will try to see from the one eye, the patient will have double vision. Okay, patient ko double vision hogi. The patient will have double vision. Now in which cases you can have monocular diplopia? Strabismus, the patient will have binocular diplopia. Binocular means whenever the patient will see from both the eyes, there will be binocular diplopia. Okay, hyphema is blood in the anterior chamber. Blood, why blood in the anterior chamber is associated with diplopia? Not at all. Eliminated. If I talk about cataract, cataract causes decrease in vision. How it is going to cause monocular diplopia? How it is going to cause? No, it will not cause monocular diplopia except for one stage of cataract, which is your incipient cataract. Incipient stage of cataract, which is early stage of cataract. All right, guys. So sorry. I know that you are having a trouble, but I am trying my best. Now I think it should start working again. Let me see. ओहो, सारी एनर्जी लूज हो जाती है नहीं एकदम से. माहौल बना होता है हमारा, बट चलो कोई बात नहीं. आई एम हियर टू रिपीट एवरीथिंग. डोंट वरी, डोंट वरी, don't worry, Dr. Panic, don't worry. So all right, so I was telling you that the answer will be your iridodialysis, because there is tearing of the iris from the root, so there will be two areas from where the light is going to enter and strike the retina. So because 2 points on the retina, they are receiving the stimulus at one time, so there will be typical diplopia, monocular diplopia. Okay, chalo. A patient suffers trauma with vegetative matter. So you know, if I talk about vegetative matter, we are talking of organic matter injury. And whenever there is organic matter injury, you have to look out for one cause of keratitis. But let's further read. So ulcer is there, hypopyon is there, satellite lesions are there. We have already done it. It is a clear-cut case of fungal keratitis. Okay. Now patient has distress on reading, right? On examination, there is no problem of short-sightedness and long-sightedness, means there is no myopia or hypermetropia, but Shermer test reading is 5. Now if I talk about Shermer's test, so normal reading is more than 15 millimeter, borderline, BL means borderline, is 10 to 15 millimeter, and if I say mild dry eyes, it is 7 to 10 millimeter, moderate dry eyes is 5 to 7 millimeter, and severe dry eyes is less than 5 millimeter. So severe dry eyes means that I am talking of the wetting of the Shermer strip. So if the wetting is less than 5 millimeter, I'll think of severe dry eyes. So you know what is the treatment. So we are talking of Shermer strip. So you know we are naturally talking of dry eyes. And what is the treatment of dry eyes? It is lubricant. Yes, absolutely, Dr. Ahmed. It is your lubricants and dry eyes, of course. Okay, now a patient presents with hard painless nodule, generally growing externally away from the lid margin. See, so there are two lesions which I think you should be aware of. I'll not be writing much, but I'll be showing you the two patients. Once you will see the patients, so it will be very, very clear. You will automatically be able to recall. So first and foremost is, check this out. So first and foremost is your sty. So this is what you see at the margin of the eyelid. Can you appreciate a small pus mark just at the base of eyelash? That is your sty. That is your sty. Wait, I am going to show you one rather more clear video of the patient. Check this out. So this is at the lid margin and it is painful, tender. Yes, are you able to appreciate? Acute, 3 days, acute condition. Typically he said pain ho raha hai. Okay, so this is at the lid margin, so that is your sty. The treatment is antibiotics, hot fomentation. That's it. Antibiotic, eye ointment, azithromycin eye ointment, moxifloxacin eye ointment. Now what is this? Check this out. Check this out. देखो, away from the lid margin. Yes, I asked whether you are having any pain, so she typically gave a history that I am feeling a little heaviness over here, but it is not paining, and she is having this from past 1 month. Chronic, non-painful or painless, away from lid margin. These are 3 important differentiating features from that of sty. Okay, now check this out. What is the treatment of sty? I told you antibiotics, hot fomentation, but here, because this is chronic, you need to excise, you need to give a small incision and take out the lipogranulomatous inflammation. IND, incision and drainage. Fast forwarding it. Okay, so I'll give a local anesthesia over the lid so that when I give a cut, there is no pain. So you will appreciate. I am just cleaning it with betadine, povidone, iodine. So this is your local anesthesia, which is lignocaine, lidocaine, xylocaine. It's one and the same thing, 2% mixed with ADR. Okay. This is chalazion clamp. I have everted it. Now I am going to give an incision. Now you will see coming out of lipogranulomatous substance. So this is chalazion scoop. I am scooping out the contents of the chalazion, and I am going to wash it with povidone iodine, betadine, 5%. Alright. So it is a very fast forwarded sort of a video so that we are able to finish everything on time. So just to give you an idea, so chalazion IND is the best treatment, while sty you will give antibiotics, antibiotic eye ointment, you can give oral antibiotics, oral anti-inflammatory, and hot fomentation. I hope it is well understood. Okay. All right. And I am putting the antibiotic ointment. Did you see that no sutures were given? So I'll just leave it as such and it is going to heal by itself. Self healing will be there. All right. चलो चलें आगे. I hope, मुझे ये लगता है ना कि अगर एग्जाम से पहले कुछ हमने ऐसे वीडियोस देखी होंगी ना, तो अगर ऐसा कोई क्वेश्चन आते तो इजीली हम अटेम्प्ट कर पाएंगे. हमें ज्यादा एफर्ट नहीं करना पड़ेगा याद रखने में उसका ट्रीटमेंट एंड थिंग्स लाइक दैट, है ना. All right, chalo. So the answer to this question is growing externally away from the lid margin. So this is your chalazion. Hordeolum externum is your sty. Sty, okay. And what is sty? Sty is infection of hair follicle. If hair follicle is not there, go for gland of Zeiss. Gland of Zeiss. Now, a patient presents with bilateral ptosis, which is variable during the day and reduces on putting the ice packs. What is the most likely diagnosis? If there is ptosis, so you put ice packs, you are actually inhibiting the enzyme acetylcholine esterase. As a result, there will be more concentration of acetylcholine in the nerve endings, due to which its action will be prolonged. And we are talking of which disease? Yes, you are right. We are talking of myasthenia gravis. Okay. Now, a visual acuity of a patient improves on looking through the pinhole. This indicates, so what happens is you first ask the patient to look directly towards the front Snellen's chart. Okay. So normally what happens is, in normal patients, the light is focused on the retina. But let's say that the new position of the retina is R1, which is posteriorly, and you will see that this is the central light. Okay. Now you will see the central light ray is still going to focus on the retina, but the light rays which are striking at the periphery of the cornea, they will be projected not on that one point but elsewhere. That is why, because of multiple focus, there is blurring of vision in myopes, right? But what you do is, if you place the pinhole, the purpose of pinhole is that there is a small hole in the center whose diameter is just 1.2 millimeter. It will allow only the central ray of light to pass through it. It is going to cut the peripheral light rays which were causing disturbance on the retina at the new R1 position. So if there is improvement on placing the pinhole in front of the eye, it actually tells me that the patient is having refractory error, not macular disease. It is refractory error. But if the visual acuity of the patient deteriorates on watching through the pinhole, that means because the central part of the pinhole is only allowing the central ray of light to pass through it and only allowing the macula to be stimulated, and you have placed the pinhole, so only the macula will be stimulated. But if the patient is having macular disease, the patient's visual acuity will decrease. Here it is improving. That is why it is refractory error. If macular disease, then it should decrease. Okay. Now, a farmer presented with pain, photophobia, watering eye, last 6 hours, you can appreciate. So this is the main lesion. This is the satellite lesion. So this is the exact image which was asked. So there was an identification arrow which was there. So the answer is satellite lesion. We have done it multiple times, so we will not invest too much of time again here. Okay. All right. Now, can you identify the given condition? So they have said that inward rolling of the lid is there, which is we have just done. It is your entropion. If there is outward rolling of the lid, it is your ectropion. What is distichiasis? Distichiasis is extra row of eyelashes, and trichiasis is when there is misdirected eyelashes. Misdirected eyelashes. So these are all the definitions that you should know. A child presents with defect in the vision, but on examination fundus is normal. What could be the diagnosis? So fundus is normal. Fundus can be normal in astigmatism, amblyopia, myopia, and hypermetropia. But now we'll look out for the other keywords. So there is defect in the vision. Okay, defect in the vision means the child is not able to see properly. Of course, all of these are having defects in the vision, but astigmatism, myopia, and hypermetropia can easily be corrected with the help of glasses. Sometimes the examiner may ask you incomplete questions. So you always have to choose the right answer depending upon the options which are provided. So with the glasses, astigmatism, myopia, and hypermetropia will be all right. But for amblyopia, you will have to go on for the proper therapy, which may be for 2 months, 4 months, 6 months, 10 months, or maybe 1 year, 2 years. And here the answer is your amblyopia, because they have specifically mentioned defect in the vision. Okay, all right. A child aged 1.5-year-old is brought by parents with leukocoria as shown, flexor wintersteiner rosettes. Now, flexor wintersteiner rosettes is the diagnostic histopathological feature of one disease. You can see leukocoria. Leukocoria is white pupillary reflex, and the answer is retinoblastoma. So no leukocoria. Leukocoria is there, no leukocoria. So congenital glaucoma, rhabdomyosarcoma is instantly eliminated. Now we are left with retinoblastoma and congenital cataract. In retinoblastoma there is flexor wintersteiner rosettes, hence the answer. After an accident from metal works, a mechanic got injured from metallic foreign body. Investigation of choice: if there is metallic intraocular foreign body, you will never go on for MRI, because MRI will lead to fast swift movement of the intraocular metallic body in the eye, which will damage the around lying structures. So NC, non-contrast CT scan, is actually the investigation of choice. B scan is actually the initial investigation, usually initial. Okay, nuclear radiology, very vague option. Okay. Now, a patient comes with paralysis of all extraocular muscles. What most probable site of lesion is? Can anyone tell me? Yes, can anyone tell me most probable site of lesion? Of course, that will be site which leads to maximum origin of the cranial nerves, and it is midbrain. The answer is midbrain. Okay, midbrain. So there is midbrain, there is pons, there is medulla, because midbrain causes origin of third cranial nerve. Yes, third and fourth cranial nerve. So third is actually, if you could recall, अगर आप थोड़ा सोचेंगे, so third, only third, not fourth, only third cranial nerve. So अगर आप थोड़ा, all right, so we are back live. So I hope audio, video all clear now. Okay, so I was telling you that you have to choose the best option here. So most probable site of lesion. Now third cranial nerve, fourth cranial nerve, they both arise from midbrain, while sixth cranial nerve arise from pons. So they have said that there is paralysis of all extraocular muscles, you know, SO4, LR6, RES3. So third and fourth cranial nerve supplies 5 extraocular muscles, right? So the best option will be midbrain here. Okay, now there is a difference in visual acuity between two eyes, the cause of decreased vision. So difference in the visual acuity of two eyes means anisometropia, and anisometropia can lead to decreased vision, which is anisometropic amblyopia. I hope it is clear, है ना? Okay, Now, biconcave lens is used in the treatment of simple myopia. If I talk about hypermetropia, it is biconvex lens. If I talk about astigmatism, it is actually cylindrical lens. Now, if there is myopic astigmatism, so you can use concave cylindrical. If there is hypermetropic astigmatism, you can go on for convex cylindrical. Okay. Presbyopia, you know, for presbyopia, you give biconvex only, but that is the physiological loss of accommodation. The most common cause of blindness in children, vitamin A deficiency. Can you tell me the most common cause of blindness in adults? It is cataract. Okay. Most common cause of preventable blindness in adults. Preventable blindness in adults. This is also cataract. Most common, if we are talking of most common cause of blindness, let's discuss most common cause of proptosis. Proptosis, most common cause in children, most common cause in adults. Okay. Now, if I talk about children, unilateral is orbital cellulitis. These are your brownie questions. They will be asked as such. Bilateral cause, neuroblastoma. I repeat, neuroblastoma. Okay. In adults, unilateral and bilateral, both. It is thyroid eye disease, TED. It is all about proptosis. I repeat, proptosis means protrusion of the eyeball. Okay. It is protrusion of the eyeball. All right. Now, next is patient had a fight. Yes. Following which he presents with non-reactive pupil and painful ocular movements. So we have already done it. So if there is retrobulbar neuritis, you are going to choose retrobulbar neuritis. If that is not in the option, go for optic neuritis. Yes, TED, Dr. Panic, it is thyroid eye disease. Most common unilateral cause, most common bilateral cause of proptosis. Okay. A mother brings her child to eye OPD with complaint of difficulty in watching blackboard. Blackboard means when the child is seated far from the blackboard, not able to appreciate it. So that is nothing but simple myopia. Okay. What could be the most probable reason? It is myopia. You know it. Patient had a fight and is brought with non-reacting pupil with painful ocular movements, again repeating in different formats. So this is optic neuritis only. Now there is a 55-year-old patient who is having open angle glaucoma. The treatment was started and you could appreciate that the color of two eyes are different. So in the eye with the treatment is having the dark colored iris. So you call it as iris hyperpigmentation. Okay, iris hyperpigmentation. The most common drug, anti-glaucoma drug that can lead to iris hyperpigmentation is actually prostaglandin analogs. The example of prostaglandin analog is latanoprost. Okay. All right. So Dr. Panics, it is in some people it is physiological. It is normal. Don't worry for it. Get your T3, T4, TSH tested and you will know. Okay. All right. Now, no, it is not timolol, my dear friend. It is latanoprost, iris hyperpigmentation. Okay. A patient who was operated for cataract 4 months back comes to you with foggy vision. Okay. On examination, following is found. Which mode of treatment is most useful? So what is this? What is this? What is this? So this is your after cataract. And we have already done what is the treatment of after cataract. You go for ND-YAG laser capsulotomy. So you can call it as YAG laser capsulotomy. A patient has a field defect where he cannot see on the left side from the left eye and left side from the right eye with preserved central vision. With preserved central vision, we have done it multiple times. This is homonymous hemianopia with macular sparing. Okay, ji. Which is the most common intraocular malignancy in adults? Mind you, most common intraocular malignancy in child is retinoblastoma, which is associated with RB gene, retinoblastoma gene. In adults, it is choroidal melanoma. ठीक है जी, very important. Now, what dye is used in staining the anterior capsule of the lens? Let me show you something really interesting. I am sure that once you will see that, you will be able to connect the dots. So I am going to show you the staining. So yeah, let me just show it to you. So what is the color of the dye which is used for staining? So whatever the color is, just mark that color in the option, and let's see if that is there in the option. So I am giving an incision. So this is the main incision with the help of keratome. This is a diamond shaped knife. Now I'm going to stain the anterior lens capsule. This is phacoemulsification, boys and girls. So which dye is this? I'm just going to show you a little part of this video, not the entire video that I usually show in my classes. So it will take a lot of time. Yes, what is the color of dye? Blue dye. Okay, so once I will wash away the dye, you will see that the capsule has been stained blue in color. So I'm going to perform a rhexis. When I am performing a capsulorhexis, means creating a small round window on the surface of the lens capsule, you will see that the capsule has been stained with blue color. Seen? Okay. All right. Now this is the rhexis which is being performed. Okay. Now getting back to the question. So yes, was it a green color dye? Yes. Was it a green color dye? No, not at all. Not at all. Eliminated. Was that rose color dye? No. Now we are left with trypan blue and brilliant blue. The answer is trypan blue dye. I hope it is clear. Now a patient who works in an iron factory presents with visual disturbances and is found to have iron deposits in the eye. We have already done that, by the way. Which of the following condition is most likely responsible for this ocular finding? Chalcosis is copper. KF ring is copper in the cornea, Descemet's membrane. Retinitis pigmentosa is absolutely a different disease. Sidrosis bulbi is iron foreign body, or intraocular presence of iron. It is sidrosis bulbi. In which type of cataract surgery is suturing with nylon 10O is commonly performed? Of course, you are going to give a suture in which the length of incision is large. In phaco, you saw me giving main incision that was just 2.8 to 3.2 millimeter, boys and girls. It does not require any suture. So you will eliminate phacoemulsification. Flax is nothing but a modification of phacoemulsification in which you use laser to perform 3 steps. Okay, that is also eliminated. Now manual small incision. Why you are going to give suture if the incision is small? You are going to give suture if the incision is large. Na? Eliminated. The answer is extra capsular cataract extraction, because here the length of incision is 10 to 12 millimeters. So you need to give sutures and you are going to use 10O nylon. Okay, if I talk about conjunctival sutures, conjunctiva sutures, which sutures are you going to use? 8-0 or 6-0 Vicryl. Okay, just an extra point. Okay, what is the drug used for refraction in a child with squint? Refraction means you are going to perform a dilated refraction. That means you are going to use a drug which is atropine 1%. You call it as cycloplegic refraction. While performing refraction means you are performing retinoscopy. Retinoscopy is an objective way. It is an objective method of assessment of the refractive error. So you first give a cycloplegic, that is atropine 1% ointment. You use ointment. You don't even use eye drops. You use ointment. Okay. All right. What are the yoke muscles for levodepression? Now, mind you, in abducted eye, I repeat, in abducted eye, abducted means outside. So if I'm talking of right eye is abducted. The elevator action is via superior rectus. The depressor is via inferior rectus. Got it? In adducted eye means if the eye is inside, the elevator is via inferior oblique. The depressor is via superior oblique. Now, if you know this, you must have gone through the notes. You must have gone through the entire ophthalmology regular notes. So you know it. Hai na? Now, in levodepression, so left eye is depressed in abducted position. Levodepression. Right eye is depressed in adducted position. So I told you In abducted position, elevator is superior rectus, depressor is inferior rectus. In adducted position, elevator is inferior oblique, depressor is superior oblique. So they have asked about levo depression. So that means left inferior rectus and right superior oblique. So you are going to mark this. Okay, all right. Now oil drop cataract is seen in, we have already done galactosemia. In Wilson's disease you are going to see sunflower cataract. In myotonic dystrophy, Christmas tree cataract. And diabetic mellitus you are going to see overall early senile cataract. Overall early senile is most common because it is seen in type 2 diabetic mellitus. Type 1 diabetic mellitus has got snowflake cataract. Because overall type 2 diabetic mellitus is more common, so the cataract which is caused by type 2 diabetic mellitus is more common, which is early senile cataract. While in type 1 it is snowflake cataract. A patient presents with vertical diplopia on walking downstairs. Means when I am walking downstairs, so I have to keep my eyes down. If I am having diplopia while looking down, that means my one eye is going down, but the other eye is not going down. That is why I am perceiving two images. These two images are leading to formation of confusion, diplopia. To correct that, he tilts his head on one shoulder. Which nerve palsy should be suspected? Now please understand, what happens is there is a concept of compensatory head posture. So you need, just listen to me, don't need to write anything. This is a revision class. So if my right lateral rectus is paralyzed, so I cannot move my right eye towards right side because of paralysis of right lateral rectus. So what I am going to do, I am going to turn my head onto the right side to compensate for the loss of action of right lateral rectus. So in other words, the compensatory head posture will always be in the direction of action of paralyzed muscle. Now if my right superior rectus is paralyzed, so I will not be able to look upwards from the right eye. So the compensatory head posture will be right sided, chin lift, so that I don't have to use my right superior rectus muscle. Now taking a step ahead, which will be our answer. The primary action of obliques is intorsion and extorsion. Superior oblique causes intorsion, inferior oblique causes extorsion. Now what will be the compensatory head posture of right superior oblique palsy? See, the function of right superior oblique is to turn the eyeball along the z-axis inside, intorsion. So compensatory head posture will be left head tilt, because on tilting the head onto the left side, my right eye is intorted, so that I don't have to take the use of superior oblique muscle to intort the eye, because the compensatory head posture has intorted the eye already, right? Now to correct that, he tilts the head on one shoulder. So head tilting is seen in oblique nerve palsy, oblique muscle palsy. समझ में आ गया? Now superior oblique is also helping the eyeball to look downwards. So when the patient move downstairs, the patient will have to focus down. Because of the paralysis of superior oblique, the patient one eye is not going down while other eye is going down. As a result of which the patient is having diplopia or difficulty in going downstairs. This is one. Now when the patient is having difficulty in going downstairs, so there can be two things. There can be superior oblique which may be involved, or there can be inferior rectus which may be involved, because both these muscles take the eyeball downwards. But there is second clue which is given, that is head tilt. Had it been inferior rectus palsy, the chin, the compensatory head posture will be chin downwards to compensate for the loss of action of inferior rectus. But here the compensatory head posture is head tilt to cause intorsion, to compensate for the loss of the superior oblique action. So here we are talking of superior oblique paralysis, and superior oblique is supplied by fourth cranial nerve, SO4 LR6 RES3. I hope it is well understood. Okay. A 60-year-old presents with chronic dacryocystitis. What should be the treatment of choice? Chronic dacryocystitis we are talking of. Okay, so chronic means it is a long lasting, so lacrimal sac massage, syringing, probing would not help. So age is 60 years, you cannot go for DCR after 65 years. So best is your dacryocysto-rhinostomy. Treatment of choice will be DCR only. Okay. On retinal examination of a hypertensive patient, okay, multiple flame shaped hemorrhages are present, cotton wool spots and disc edema. Whenever there is disc edema, that is your extreme grade, which is grade 4. Okay, if I talk about flame shaped hemorrhages, it is seen in nerve fiber layer. And also in grade 4 you see silver wiring of the arterioles, they look like silver wiring. Now grade 3 it looks like copper wiring. Okay, grade 4 boys and girls, it will be grade 4 because of edema na, disc edema will be grade 4, disc edema, there will be silver wiring, and copper wiring will be in grade 3. Grade 2 will have Gunn sign, hump sign, Salu sign, the signs will be there. A patient of HIV with low CD4 count presented with the following finding. What is this typical finding? This is your pizza pie appearance, pizza pie retinopathy or sauce and cheese retinopathy, and this is nothing but your CMV retinitis. Now the examiner is interested in knowing the treatment. CMV retinitis treatment is your ganciclovir. Visual blurring in papilledema is called amaurosis fugax. Simple. ठीक है. Hemianopia is day blindness, not able to see clearly when the patient moves from dim lit room to bright lit room. Day blindness. It is seen in nuclear cataract. Just extra points है ना, nuclear cataract. Malingering is that the patient is normal, the patient is acting. Malingering is falsely saying that the patient is not able to see when actually he can see everything. Blindness is blindness. So visual blurring in papilledema, visual blurring, that is amaurosis fugax. In which condition is pupillary light reaction absent and accommodation reflex present? So ARP and PRA, you inverse ARP, you get PRA. Accommodation reflex present, pupillary reflex absent. It is seen in ARP is Argyll Robertson pupil, and the cause of Argyll Robertson pupil is, boys and girls, your neurosyphilis. ठीक है जी. Okay. Now in patient presented with recurrent chalazion, which cancer is suspected? Now mind you, if the patient is having recurrent stites, if the patient is having recurrent stites, you will suspect a refractory error. Okay, if the patient is having recurrent chalazion, you will suspect sebaceous cell carcinoma. Two important MCQs. Very good, all of you. Yes. Normal flora in conjunctiva. Can you tell me? Normal flora. This is your PYQ. Normal flora in conjunctiva is whether it will be staph aureus or staph epidermidis. Yes. Quick. Waiting for your responses. This is a recent PYQ, so you should know. Yes, quickly. जल्दी बताइए, जल्दी. Staph aureus, staph epidermidis. जल्दी. We have to finish. इससे पहले OBS साहब फिर बंद हो जाएं. One is epidermidis, another is aureus. Okay, anyone who would like to try, or should I give the answer? Because this has been repeated quite a number of times and this was asked in last year, so I want all of you to know. Yes. Normal is staph. Epidermidis. Okay. Normal is staph epidermidis. Sudden painful loss of vision with mid-dilated pupil. So that is your acute congestive glaucoma. Mid-dilated pupil, which is non-reacting. Mid-dilated pupil, which is non-reacting. Okay. All right. But if there is sudden painful loss, if there is sudden painful loss with constricted non-reacting, NR means non-reacting pupil, then it is anterior uveitis. Okay, that is the difference. History of intake of ATT with loss of vision. Most probable drug is ethambutol, single liner. You must have read it in your pharmacology. Vitamin A deficiency is seen in Bitot spots. We have read it. And what is Stocker's line? Stocker's line is seen in pterygium. And this line is nothing but iron deposition. This is iron deposition on corneal epithelium, just ahead of pterygium. July exam, there was more on sudden painful and painless questions were there. That is why, yes, absolutely. That is why I have given you another sudden painful loss with constricted pupil, non-reacting pupil, irregular pupil. You will go for anterior uveitis. Irregular pupil. If there is mid-dilated pupil, sudden painful loss, you will go for acute congestive glaucoma. Yes, good. History of blunt trauma. Blunt trauma is there. Complicated cataract? No, complicated cataract is seen in myopia, uveitis, retinitis pigmentosa. Christmas tree cataract, myotonic dystrophy. Sunflower cataract, Wilson's disease. Trauma is rosette cataract. Trauma is, yes, very good, Dr. Ahmed. Yes, of course, Dr. Ankush Anand. That is why I am also teaching you how to eliminate the options based on the keywords. That is the reason that we are investing so much of time, right? Okay. So how will you remember this rosette cataract? So there was a Valentine's Day. You know, in today's world, it is very much common. Na? I like you, but as a friend. So there were two friends, one boy and a girl. The boy had started liking the girl, but the girl, as most of the girls, took him that she likes her, but she likes him, but as a friend. So on Valentine's Day, the boy went up to the girl with a rose in his hand. He bent on his knees, offered the rose to the girl. The girl got so angry. The girl slapped the boy so hard that the rose that he was carrying got stuck in his eye. So rose that he was carrying, so blunt trauma is slap, right? And the rose getting stuck in his eye is a rosette cataract. So blunt trauma is associated with rosette cataract. All right. So I think Dr. Panic is having post-traumatic stress disorder. Huh? All right. Okay. So difference in refractive power in two eyes is +5 diopter in one eye, +1 diopter in another eye. So probably this is anisotropia. This we'll know. Hai na? But what is the diagnosis? So this anisotropia can lead to amblyopia. This anisotropia is in fact the most common cause of amblyopia. So the answer is 3, which is anisometropic amblyopia. Curtain falling sign is seen in, we have read it in the clinical vignette, clinical format, that it is seen in retinal detachment. Which of the following is not a local anesthetic? See, lignocaine is a local anesthetic. Lignocaine, xylocaine, lidocaine, it's one and the same thing, local anesthetic, and it is used 2%, so it is correct. Okay. Proparacaine, it is a topical anesthetic. Topical means it is used in the form of eye drops. Bupivacaine is local anesthetic. Prilocaine is local anesthetic. Okay, so the answer will be proparacaine. And mind you, if bupivacaine is given at 0.75% concentration, it is better than 0.5. So out of given 4 options, proparacaine is the best pick, which is your topical. They have asked which of the following is not a local anesthetic. Okay, local. So proparacaine is actually topical anesthetic. Now, which of the following is the corrected refractory errors? The same image was asked, but we could not get what the examiner wanted to know. But I would just explain you. If the image is formed in front of the retina, that is your myopia. If it is formed behind the retina, hypermetropia. If it is formed at one axis while not formed at another axis, it is astigmatism. Now, this is the basics. So once you have understood the basics, whatever image is there, you will be able to mark. So we don't know about the proper image which was asked. So there were different options. So it is based on the recall only. So I will not mark anything here, but I have explained you myopia, hypermetropia and astigmatism. Now, cherry red spot is seen in. Now, Tay-Sachs, yes, it is seen. Gaucher's, yes, it is seen. Fabry's, no. Wilson's, no. Out of Tay-Sachs and Gaucher's, mark Tay-Sachs because Gaucher's and GM1 gangliosidosis, they are the last options to be picked in case of cherry red spot. I hope you have understood that. So what are the other conditions in which you see cherry red spot? It is CRAO, central retinal arterial occlusion. Then trauma. The cherry red spot seen in trauma is known as Berlin's edema. Okay. Then Niemann-Pick disease. Then Gaucher disease and GM1 gangliosidosis. Then Tay-Sachs disease. Then Sandoff disease. These are few diseases that can lead to cherry red spot, but mind you, Gaucher and GM1 gangliosidosis, they are last to be picked. Yes, Dr. Panic, Tay-Sachs, Niemann-Pick, they cause cherry red spot. Sudden loss of vision with no fundal glow. There is no history of trauma. What do you feel? So I am going to show you a very interesting case. So you will see it for your own self, and then you will let me know what do you see, because once you will see it, your concept will be crystal clear like anything. Check this out. So red reflex, can you see? Red reflex is seen with the help of distant direct ophthalmoscopy. You stand at a distance of 25 centimeter, watch through the direct ophthalmoscope, put it on the retina. The light will strike the retina, will be reflected back. So in one eye you can see the light, in another eye you cannot see the light. So it is seen in vitreous hemorrhage. Because of the hazy media, it is not allowing the light to pass. So the light is not striking the retina, it is not getting reflected back. So this is a case of vitreous hemorrhage. Okay ji? Alright, you must have seen while taking the photographs with the flash of light, there is red eye. What is that red eye? That is nothing but the lights striking the retina and is reflected back. So it is your vitreous hemorrhage. It is your vitreous hemorrhage. Wait, yeah. So the answer is vitreous hemorrhage. Now coming over to name of the instrument. Which instrument is this? So nowadays the name of the instruments are also asked. So yes, let me just scroll it and then we shall start. Okay, just a moment. Yes, wait, yeah, just a moment. So nowadays the name of the instruments are asked, so we need to be very well known of the instruments. So this was the instrument which was recently asked in your exam. Yeah, can you tell me the instrument? What is this? Can you tell me? So this instrument is used to keep the eye open while operating upon a patient, and that is your speculum. Okay जी, तो ये है हमारा speculum. ठीक है? Okay, and there are some other instruments. This is your side port. This is the crescent. Crescent is, you'll see that this is like this, and this is keratome, sharp tip, diamond shaped. All right. A corneal wisp test was performed. Wisp test is, you take the cotton, ask the patient to look right in the front, touch the cotton on the side of the cornea. There will be blinking. So you get to know about the blinking reflex, whether it is present or not. And the blinking reflex is formed. Any reflex in the body has got two components. One is the afferent component, another is the efferent component. The afferent component of blink reflex is formed by trigeminal nerve. The efferent is due to I am blinking now, so it is 7th cranial nerve because of the involvement of orbicularis oculi. So it is 7th cranial nerve. 5th is trigeminal nerve. So the answer is, they have asked about afferent, so you will mark trigeminal nerve. ठीक है जी. The cover uncover test is performed to diagnose various eye conditions. Okay, all right. Which of the following is not detected by this test? So there is cover test, there is uncover test. You know it is used in squint. Now squint, both latent and manifest squint. So if you are performing cover uncover test, now you have eliminated the squint, but there are some more conditions which can be detected by cover uncover test, and after removing these two, even if you don't know anything, you still get 50% of the chances of marking it correctly. So the answer to this is amblyopia, because when you perform the cover uncover test, the latent nystagmus becomes manifest for some time, right? So the best answer here is amblyopia. Amblyopia is stimulus deprived loss of vision without any organic cause. So the answer is amblyopia here. Okay, I know most of you would mark latent nystagmus, but what is amblyopia? How will you diagnose amblyopia? Amblyopia means when the patient's visual acuity is decreased despite the organic cause is not there. How are you going to test the visual acuity? By simply testing the Snellen's chart, na? Isn't it? So how cover uncover test is going to help in that? It is not going to help, hai na? So the answer to this question is amblyopia. Which of the following is a side effect of PG analogs? Uveitis, yes. Orbital cellulitis, no. Hyperemia, no. Keratitis, no. Simple. So hyperemia is commonly seen with rho kinase inhibitors. ठीक है जी. All right. Keratitis, no, not really. Keratitis not seen. Okay. A 5-year-old child presents with refractive error of 1D in left eye and minus 2D in right eye. मतलब +1 and -2. That means the difference in the refractive power is 3 diopter. Fundus examination reveals normal visual acuity and retinal findings. What is the most likely diagnosis? So there is difference of 3 diopter. So it is your anisometropia. I hope it is clear. है ना? We have done it in the previous questions. A patient presents with right-sided field defect in both eyes, but the central vision remains unaffected. This is almost getting repeated the 3rd or 4th time. So it is like this. Right-sided field defects. Right-sided means like this. Okay. So this is homonymous hemianopia with macular with central sparing. What is the most likely diagnosis? With macular or with central, it's one and the same thing, but one is homonymous hemianopia, another is heteronymous. So it is not heteronymous, it is homonymous. That is, it is on the same side. Very good. A patient presents with vision problems and has a history of cataract surgery. Okay, OCT finding is shown below. What is the syndrome most likely associated with these findings? What is this? This is your clear-cut case of cystoid macular edema. You can see intraretinal cyst, and this image is your OCT scan. OCT is optic coherence tomography, and you can see that there are intraretinal cysts. These cysts are present in Henle's layer. The other name of Henle's layer is outer plexiform layer, and if it happens to be after uneventful cataract surgery within 1 to 3 months, this is particularly known as Irwin gas syndrome. All these are important points. How will you prevent it? You can prevent it by giving prophylactically eye drops, and that is your topical NSAIDs. Topical NSAIDs, which is Nepafenac, Bromofenac. Nepafenac, Bromofenac. All right. Now a patient sustained blunt trauma to the eye 6 months ago, and now presents with blurring of vision. What is the most likely condition? So the image is provided along with image दी हुई है साथ में. आप देखेंगे in blunt trauma there are high chances of iridodialysis. So in iridodialysis there is tearing of the iris at its root. तो देखेंगे tearing of the iris at its roots, and it also leads to, as we have read previously as well, uniocular diplopia. Why? Because of the tear of the iris, the light ray will pass through here, the light ray will also pass through here, so it is going to stimulate two different points on the retina, and on closing the normal eye, because with one eye I am seeing two images, because of the two light rays stimulating two different points on the retina, I'll be having uniocular diplopia. Okay, all right. What is ankyloblephron? Ankyloblephron क्या होता है, कोई बताएगा? Yes, ankyloblephron is adhesion between upper and lower eyelid. This is ankyloblephron. Since we are doing ankyloblephron, कोई बताएगा? Symblephron क्या होता है? Symblephron is adhesion between bulbar and palpebral conjunctiva. Palpebral and bulbar conjunctiva. Adhesion. What is Vossius ring? Vossius ring is pigment dispersion on anterior lens capsule seen in blunt trauma. I am writing it here. In blunt trauma, there is pigment dispersion on anterior lens capsule. All these are very, very important. Or cycloiriditis, it is nothing but the other name of anterior uveitis. All right. Okay, now moving on to the 100th question. A 5-month-old baby is brought by the mother with complaints of the left upper eyelid moving up and down during breastfeeding. We have seen the real patient, and that of, you already know, that is Marcus Gunn jaw wing syndrome, right? So we will not be discussing it here. We have already discussed this. Yes, a patient with a long-standing history of diabetes mellitus presents with cataracts. Which of the following metabolic product is primarily responsible? So we have done, it is sorbitol plus fructose. If that is not in the option, go for simply sorbitol. If sorbitol is not there, go for simply fructose. A patient has a history of flying foreign body injury to the eye. Ocular findings revealed iris pigmentation. Okay, which of the following substances is most likely involved in the deposition? If there is iron foreign body, it is going to get dissipated into ferrous and ferric, which will cause increased iris pigmentation. So the answer is iron. Overall, most common foreign body to enter the eye is iron only, and the most common cause is chisel and hammer injury. Chisel and hammer injury. Okay, which of the following statements is correct regarding indirect ophthalmoscopy? So there is slit lamp biomicroscopy, there is direct ophthalmoscope, there is indirect ophthalmoscope. So indirect ophthalmoscope, there is image which is real and inverted. Real and inverted. Okay, so that is not the correct point. It provides 15x magnification. No, it provides 3 to 5x magnification, which is the answer. The condenser lens needs to be kept close to the eye. No, you need to keep it far to the eye. So we have eliminated each option. The final answer is D, which is 3 to 5x magnification. A patient presents with breathlessness and is diagnosed with Pancoast tumor. Pancoast tumor is the tumor of tip of lung. So you know that there is Horner's pathway. So there are sympathetic fibers which are from hypothalamus going till CA-T1, from where they move anteriorly between the tip of the lung and the clavicle at the inferior cervical ganglion. Then they go towards superior cervical ganglion. Then they loop around internal carotid artery to enter into the cranium, and then they move anteriorly and supply dilator pupillae. This is the entire Horner's pathway for sympathetic fibers. Now when there is Pancoast tumor, there will be compression of the sympathetic fibers between the clavicle and the tip of the lung, leading to its damage, as a result of which there will be oculosympathetic palsy. So the pupil will be constricted, meiosis, there will be anhidrosis, loss of sweating on that half of the face. There will be ptosis, but this ptosis will not be full ptosis. This will be a partial ptosis due to involvement of Muller's muscle, which is supplied by sympathetic fibers. If there was full ptosis, it would be because of the third cranial nerve injury, which will supply levator palpebrae superioris. Here there is partial ptosis. Now partial ptosis will give an appearance as if the eyeball has turned inside, it has sunk in. So it will give an appearance of that of enophthalmos. Now this enophthalmos is not true enophthalmos, that is why it is known as pseudo enophthalmos. Now in the given options, ptosis is present, although it is partial, but it is present. Meiosis is present, anhidrosis is present. Exophthalmos is not present, it is not exophthalmos, although enophthalmos is also not present. But we say that in Horner syndrome there may be enophthalmos, but this enophthalmos is not true, it is false enophthalmos because of the partial ptosis. It gives an appearance as if the eyeball has sunk in when actually it hasn't. Okay, all right. A patient presents with proptosis that increases when bending down. So that sort of proptosis is your intermittent proptosis. Now one cause of intermittent proptosis is orbital varices, because when the patient lies prone, there is collection of the blood behind the eyeball which pushes the eyeball anteriorly. So there is proptosis. But when the patient lies supine, all the blood gets drained due to gravitational effect and the proptosis is gone. All right. A patient visits emergency with history of trauma. You know, we have done it multiple times. This is your inferior wall fracture. Okay, no guys, why cavernous sinus thrombosis? So they have said that it increases when bending down. That's it, intermittent proptosis. But there is another form of proptosis. Remember, in carotid, I am telling you little more because I can see that you are answering incorrectly. Carotid cavernous fistula, there is typical proptosis which will be lup dup 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 like this. So what is this proptosis which is called? This is what sort of proptosis? Yes, moving to and fro. Can you tell me? I have told you that in carotid cavernous fistula we see a particular type of proptosis. What is this? So intermittent proptosis I have told you, but what is this? Okay, I am going to show you. Yes, very good, someone has rightly answered. I have shown you, someone has rightly answered. Just give me a second, I am going to show you a video, very interesting video. I am going to show you a video if I have it here. Wait, I'll show you in a while. Just give me a second. So that is your pulsatile proptosis. Okay, pulsatile proptosis, very good, pulsatile proptosis. Okay, now coming over to 107th question. A 25-year-old with gradual loss of vision. Just give me a second, guys. Just give me a second. I'll just be right back. Just give me a second. All right. Yeah. Sorry. Yeah. Okay. So yeah. So you can see that there is gradual loss of vision at night and the fundoscopy image is shown. So can you appreciate a typical bony spicule pigmentation which is present at mid periphery? Mid periphery, there is pale and waxy disc. There is pale and waxy disc. There is also arteriovenous attenuation, means thinning of the vessels. Now this is a typical presentation of one disease, and that is your retinitis pigmentosa. Okay. And why retinal hemorrhage, Dr. Panic? No, it will not be retinal hemorrhage. Retinal hemorrhages will be dot and blot type, flame shaped type, and they will also be associated with soft exudates, hard exudates, right? But here you can appreciate the pigmentation at the mid periphery, which is kind of very typically seen in retinitis pigmentosa. है ना? All right. Now, so the answer is first, which is retinitis pigmentosa. Now coming over to one important test, that is your Wirth 4-dot test. So what we do in Wirth 4-dot test is a palette is shown to the patient. So there are two green dots. Now please pay attention, very important, one red dot and one white dot. So in front of right eye there is a red filter, in front of left eye there is green filter. Okay. Now the patient is shown this palette. So from the left eye, because of green filter, the patient is only going to see two green dots and one white dot which will be converted into green. Okay. From the right eye, the patient is going to see one red dot and one white dot which will be converted into red. Now overall with both the eyes, because the binocularity of the vision is present, so you know that the left eye, right eye, they both fuse the images together. So when two red dots from the right eye and three green dots from the left eye, they are fused together, ultimately the patient is going to see two green dot, one red dot and one white dot which will be converted into red and green color, right, or orange colored dot. So normally the patient is going to see this palette. I hope you have understood. This is very normal. Okay. Now what happens if the patient is having right, I am saying right esotropia. Now mind you, the nasal retina interprets the temporal visual field, the temporal retina interprets the nasal visual field, the inferior retina interprets the superior visual field, the superior retina interprets the inferior visual field. Now if the right eye has turned inside, now the fovea which was receiving the images of the palette, so fovea is shifted outside such that now it is the nasal retina which is in front of that palette. But nasal retina interprets the temporal visual field. So two red dots are now not falling on the fovea of the right eye. The two red dots are actually falling on the nasal retina of the right eye. समझ आ गया इतना? Now nasal retina interprets the temporal visual field. Now stimulation of the nasal retina, the brain will sense that since the nasal retina is being stimulated, so these two red dots must be on the temporal side when they are actually in the front. Why? Because the two red dots are not moving on to the temporal side. In fact, the eyeball is rotated in such a way that the nasal retina is being stimulated. So the brain will show the image, the brain will see the image like there are three green dots right in the front, but the two red dots are shifted onto the temporal side. So this palette is seen in esotropia. The same goes with exotropia. If the eyeball has turned outside, it is the temporal retina which is being stimulated, and brain will think that it is actually the nasal side the two red dots are lying, not in the front. So this is seen in exotropia. And if there is 5 dots, 3 green, 2 red, anyway, right side, left side, so both of this will tell you that the patient is having diplopia. Very important. But now when the patient is having diplopia, the brain can adapt in two ways. One way is that the brain will try to suppress the image provided by the squinting eye so that there is no confusion. If that happens, you call it as suppression. So what if there is right eye suppression? Which colored dots were being contributed by the right eye? Red colored dots. So if the patient is seeing 3 green colored dots, so you will call it as right eye suppression, because now the brain is not interpreting the 2 red dots seen by the right eye, because it was creating unnecessary confusion. Now what if there is visibility of only 2 red dots? That is when there is left eye suppression. So the component which is provided by the left eye, which is green dots, is no more interpreted by the brain. Left eye suppression. Now what happens is, I told you that image, if I am seeing from both the eyes, the images are falling on the fovea of both the eyes, right? But when there is squint, so one image is falling on the fovea, another image is falling on the nasal retina of the other eye. So that is why there is no fusion, because as per law, there will only be a fusion when the images are falling on the corresponding points on the retina. So 2 corresponding points on the retina are fovea. But when one fovea and one nasal retina is being stimulated, they are not falling on the corresponding point, so it will not be fused. That is why the patient was seeing 5 dots instead of 4 dots. But I told you the first adaptation, which is suppression. The second adaptation is that the brain learns to fuse the images which are falling on non-corresponding points. So even when the patient is having squint, the patient will not have diplopia. The patient will still be able to see. The patient will still be able to see this palette. Why? Because of a concept which is your abnormal retinal correspondence. Abnormal retinal correspondence. So I know that this is slightly difficult concept, but since this is just a revision class, so I have touched a little bit of it, not the entire topic. The entire topic is worth 20-30 minutes long. So you can always WhatsApp me your doubts and I'll be happy to reply to you via voice message if you don't get it. But for now, going to the question, what is suggestive by these 3 green colored dots? This is your NEET PG 2024 question. This same image was asked, NEET PG 2024. So if the patient is seeing 3 green dots, so that means there is a right eye suppression. Right eye suppression. Okay. All right. Ptosis in Horner syndrome is due to, I have already told you, Muller's muscle, because its supply is sympathetic fibers. Sympathetic fibers. Yes, Dr. Panic, you can watch Worth 4 dot test on YouTube, which is Ophthalmology by Dr. Manish Chabra. So it is 25-30 minutes long. I've explained it, so you will understand. In case you don't understand, you can get back to me. Hai na? All right. So identify the image. Can you see that? What is this? So you know that for right eye and left eye, the blind spots, they lie onto the temporal side. So this is the left eye visual field, this is the right eye visual field, and you can actually see that overall blind spot appears kind of enlarged in the visual field. So this is a perimetric chart or visual field chart. So this is your enlarged blind spot, and enlarged blind spot is seen in papilledema. It is seen in papilledema, and blind spots are your physiological scotomas. Physiological scotomas, blind spots, they present onto the temporal side. So for right eye, it will be present onto the right side. For left eye, it will present onto the left side. So the answer is D, which is enlarged blind spot. So normal blind spot is small. Now here it looks so much of enlarged and it is seen in papilledema. They have just asked about the identification of image. This is also NEET PG 2024 MCQ. So it is enlarged blind spot. So this is what, this is just an example. This is altitudinal visual when there is tearing of the iris from its root. So this is your normal pupil. This is your normal pupil and there is tearing of the iris from its root, ultimately leading to 2 points from where the light is going to enter in the eye, from this point, from this point. So 2 points on the retina will be stimulated, leading to double vision on closing of one eye. Typically monocular diplopia, the answer is iridodialysis. It is iridodialysis. It is done है, हो गया. I think it's done. Confirm करिए sir. Done. Oh great. Starting. Thank you. So all right everyone, so we are back again. So we are just going to end this. All right. Now, which of the following is false statement regarding the image? So as you can see, there is bilateral scleral show, bilateral proptosis. Now, based on the options, this is again your NEET PG 2024. No specs grading is used, which is correct. No specs grading is used in thyroid eye disease. Can sometime lead to vision loss. Yes, there can be vision loss if there is intraorbital inflammation which compresses upon the optic nerve that causes its ischemia. Okay, eye finding reversal correlates with thyroid hormone status or can be seen in 10% patients without hyperthyroid state. So false is eye finding reversal correlates with thyroid hormone status. No, it does not actually correlate. So but it can be seen in 10% of the patients without hyperthyroid state. Okay, all right. Now coming over to the next point. Yes, D. It is D. All of you are right. A 15-year-old presented with growth in eye. What is the diagnosis? So you can appreciate there is eyelash. This eyelash not is usually present here. So this is your choristomatous tissue. Choristomatous tissue, that means choristoma. Choristoma is the growth of the tissue at a place where it is not usually present, and this is present at the limbus. It is limbal dermoid. Image based question, limbal dermoid. A patient has a history of cataract surgery 3 months back with progressive deterioration of vision. You can appreciate what is this. This is after cataract, posterior capsular opacity, and you know the treatment is via ND-YAG laser capsulotomy. Yes. Now, which of the following is not a treatment for amblyopia? This is a pretty recent advances based question. So for the treatment of amblyopia, we have been reading that patching is the treatment. You always patch the normal eye, and an isometric metropic amblyopia, refractive error correction. First you will go on for refractive error correction, then you will go on for patching. Okay, now you will think about strabismus surgery and video games. Let me tell you that playing video games is actually the new treatment in which the red blue glasses are given to the child, and there is some software which is downloaded in the parent's desktop or laptop, and the child is asked to play video games 30 minutes daily, and there are nearly 50 to 60 sessions which are conducted, and the video games are made in such a way that since the child is wearing red and blue glasses, at one time it is going to stimulate the right eye, at another time it is going to stimulate the left eye. So video games is a new technique under the name binox therapy. But if we are talking of the treatment, strabismus surgery is not leading to treatment of amblyopia. After treating the strabismus, you have to go on for patching. Okay, but an isometropic amblyopia, refractive error correction and patching. So the best answer here is strabismus surgery. Okay. A farmer with cataract surgery presented after 2 weeks with decreased vision. On examination, there were anterior chamber cells and flare with hazy vitreous. What can be the cause in this patient? So cataract surgery just 2 weeks, after that, and decreased vision is there. Probably there is endophthalmitis because there are cells in the anterior chamber, and vitreous is hazy, there are vitreous exudates. So that actually tells me that there is inflammation of the aqueous humor, inflammation of the vitreous humor, and choroid and retina as well. Okay, that is actually endophthalmitis when there is typically sparing of the sclera. Okay, but they have asked which is the common microorganism. So in early weeks within cataract surgery, that means 6 weeks, if the patient is presenting within 6 weeks, you will suspect staph epidermidis. If that is not in the option, go for staph aureus. If the patient is presenting after 6 weeks, then you will go on for Propion bacterium. So here the answer is A. Yes, you are right, Dr. Panic. It is staph aureus. Advanced cases of diabetic mellitus. What is the cause of retinal detachment? Okay, it is tractional because in advanced cases there is PDR, which is proliferative diabetic retinopathy, and proliferation means there is neovascularization, and neovascularization is leading to tractional retinal detachment. The medium used for storage of cornea and the sutures applied are, so one is moist chamber. Moist chamber is okay, it is for very short duration, but the sutures are not silk, just eliminate this option. So Optisol, okay, but the suture is not vical, just eliminate it. Polyethylene glycol and nylon, no, polyethylene glycol solution is not used. Nylon, yes, they are the sutures. So the storage medium is MK medium. It is MK medium, and the sutures which are applied is nylon. I am going to show you that I had stored the cornea in MK medium. Let me just show it to you. This is the MK media. You just check this out. So here at the bottom there is corneal scleral button, which I have put McCartney-Kaufman. Okay, all right. So you will see now. Can you see that there is sclerocorneal button which is placed inside? So this is the storage medium, and whenever you apply sutures, so that is your nylon 10-0 sutures, which we have read already. Okay, all right. Definition of blindness as per WHO, it is visual acuity less than 3/60 after correction in better eye, means best corrected visual acuity. But as per NPCB, it is the presenting visual acuity. Acute hemorrhagic conjunctivitis is caused by, so there is epidemic keratoconjunctivitis, there is acute hemorrhagic conjunctivitis. Epidemic keratoconjunctivitis is adenovirus, acute hemorrhagic conjunctivitis is Coxsackie A24 and enterovirus 70. But the most common out of both of these is enterovirus 70, which you will mark here. Now coming over to the last question, then we are going to end this session. So but wait. So there is actually multiple options. So one is B and C, another is A, B, C, then A, B, C, D, then B, C, D. So based on this, I told you Coxsackie and enterovirus 70. So the answer is B and C. Okay, all right. Best test to visualize all layers of retina. Remember, I showed you the OCT image of cystoid macular edema, in which I could tell you that there were intraretinal cysts in Irvin-Gass syndrome. So best investigation is OCT. Fundus fluorescein angiography is to assess the retinal vasculature. Perimetry is to test the visual fields. Remember, I showed you enlarged blind spot, that was visual fields. B scan is nothing but the ultrasound of the eye. It is ultrasound of eye. So the answer here is your OCT. That is the best answer. So boys and girls, with this we have completed 120 MCQs. I have covered nearly last 5 years of PYQs, and we did not rush at all. So the basic idea was to teach you the idea of eliminating, and I was telling you side by side more previous year topics, not only these 5 years but beyond that. That okay, thyroid eye disease is most common cause of unilateral bilateral proptosis in adults. So what are the causes of unilateral bilateral proptosis in children, like this. So we covered multiple topics, we covered most of the things, also most important topics. So that was my idea, and thank you for bearing with me. I know बीच बीच में OBS में issue आ रहा था, but you guys were full support, and thank you very much. If you have any doubts, अगर आप पढ़ते टाइम कोई भी डाउट का सामना करते हैं तो यू कैन ऑलवेज गेट बैक टू मी. आई एम ऑलवेज एंड ऑलवेज अवेलेबल. माई फोन नंबर इज 9814111330. You can send me a WhatsApp with your doubts and I'll be happy to get back to you as soon as possible. So इस बार 200 पार, and we at Medway wish you all the very best for your upcoming FMG exam. We are pretty sure that once you will clear your FMG exam, तो आप लोग मुझे Medway Center दिल्ली में ज़रूर मिलेंगे, and it will be my pleasure to see you, to meet you personally. Best wishes from my side. I'll be looking forward for your feedbacks. Do let me know how you felt after attending the session, and yes, best wishes from my side. Ciao.